Okay. Very good evening to everyone. Ladies and gentlemen, it's my privilege to welcome you all to the 30th annual Cuticon of IADVL HSB. I, Dr. Gaurav Bhaskar, will be your host today. First, I would like to thank everyone for taking time out of their busy schedules and making this event a spectacular one with their esteemed presence. Let's begin the event with Ganesh Vandana.
मैं उसे बोला ना कि मैं लाइव कॉन्फ्रेंस नेशनल कॉन्फ्रेंस अटेंड कर रहा हूँ 40 मिनट्स लेके आने मुझे हैं ठीक
Today, we'll be having three sessions. First, e-poster presentation. Second is the free paper presentation. And third, there will be a panel discussion on seborrheic dermatitis, current and imaging treatment options, moderated by Dr. Anil Ganju. We shall now start with the first academic session. For that, I would like to invite, welcome sir, welcome ma'am. I
थैंक
would
यू
like to hand over now the stage to Dr. Raj Raman and Dr. Preeti Mehta.
गुड इवनिंग एवरीवन
Good evening, sir.
डॉक्टर प्रीति आर I think Dr. Preeti is not online or still she's not connected.
She
So,
is still mute.
still mute. So let us start the e-poster session. First of all, I would like to thanks Dr. Rohit and Dr. Sneha for giving me this opportunity to chair this session. So we are going to start the e-poster session and every participant will get 3 minutes. So please stick to your time. So first of all, we are starting with Dr. Disha Chakraborty. So Dr. Disha Chakraborty, please start your presentation. Dr. Disha?
Yes,
Yeah,
sir.
yeah, we can see you. Yeah, Dr. Disha, you can start. Hello, Dr. Preeti, you are still muted. Dr. Disha, you
Sir,
can
my
start.
connection. Sir, my I can't hear.
Okay.
Sir, I can't hear you.
Sir, I think there's some issue with Dr. Disha's network, sir. Can we
So
move
let
on to
us,
the next participant?
yeah, let's move on the next
Yes,
participant.
yes, sir.
I would
We'll come back
request
to Disha later.
Dr. Shruti Sharma to start the presentation. Dr.
Uh,
Shruti, you are
yes,
online?
sir. Yes, sir. Good evening, sir. So, where do I find my option to start the presentation?
Yes.
Sir, I cannot find the option.
Dr. Shruti, I am going to be sharing the screen, the presentation that you have sent to us.
Yes,
Okay,
yes,
I'm just
ma'am.
sharing
Yes.
that. Give me a moment, okay?
Okay, okay, ma'am. Ma'am, my voice is not audible in the video, the presentation.
Doctor, can you present your topic yourself live? Is that okay?
Yes, ma'am. Can you please
Okay.
start from the beginning?
Yeah, yeah. No, no. You will have to open your presentation now. Share your screen.
Uh, Ma'am, I can see my presentation on the screen.
You stop sharing. Yeah, stop. Yeah.
Uh,
Ma'am, should I start speaking my
Yeah,
presentation?
please start speaking and share your screen, please, with the presentation.
How do I share my screen?
डॉक्टर श्रुति शेयर स्क्रीन का ऑप्शन है नीचे आप कर्सर में जाओगे ना शेयर स्क्रीन करके आप पावर पॉइंट ऑन कर लो अपना
Sir, where is the option, sir? मिल नहीं रहा, sir.
मैम कर्सर को नीचे लेके जाओ बिल्कुल लैपटॉप से सबसे नीचे मैम कर्सर पे जूम पे जहाँ खोल रखा ना कर्सर नीचे लेके जाओ अपना वहां पे शेयर स्क्रीन का ग्रीन ऑप्शन है मैम
मैं मोबाइल पे हूँ डॉक्टर सब्बीर मोबाइल पे कहाँ पर है ऑप्शन
मैम मोबाइल में साइड में आता है नीचे जहाँ जूम पे है ना उसमें नीचे ही आता है मैम
सर मैं भी मोबाइल पे हूँ मिल नहीं रहा है ऑप्शन मीटिंग सेटिंग्स में
1 मिनट मैं मोबाइल पे बताता
uh,
Like for many of us, this is the first time somebody is presenting, so there will be definitely hitch. So once your hitch is out, then next time you will be ready.
स्नेहा मैम स्नेहा मैम am I audible to you
Audible, please tell me.
ma'am can you please play the presentation I've sent you
Yeah, sure. I'll do that, and you will be speaking then.
yes ma'am
I'll mute you. I'll mute your voice that you have sent me, the audio presentation that you have sent me. I'm
yes
muting you
ma'am
there. Okay. So
डॉक्टर
I'll
श्रुति
play this.
मोबाइल में भी सबसे नीचे ही है
Start now.
yes ma'am
Okay. All the best.
thank you ma'am
I'm sharing the screen. Just give me a minute.
yes ma'am
This seems to be a network issue.
Good evening. I am presenting a case series of congenital vitiligo from North India, clinical and dermoscopic correlation. Vitiligo is an acquired melanocytic skin disease of multifactorial etiology, which affects around 1% of the general population, with half of them having onset before 20 years of age. Very few cases of congenital vitiligo have been reported, and the first was reported by Lerner and Nordland in 1978. Case 1. A 2-month-old male baby presented with a depigmented patch on the back of neck since birth. On wood slam, blue-white fluorescence was seen. Dermoscopy revealed ill-defined borders, reduced pigmentary network, perifollicular pigmentation, leukotrichia, satellite lesions, and comet tail appearance. We made the diagnosis of congenital vitiligo and prescribed topical hydrocortisone. Case 2. A 2-month-old male baby presented with a well-defined depigmented macule on front of abdomen since birth. History of mucosal vitiligo was present in the mother. Blue-white fluorescence was seen on wood lamp. Dermoscopy showed well-defined borders, reduced pigmentary network, perifollicular pigmentation, and tapioca sago appearance as shown in the figure. We made the diagnosis of congenital vitiligo and gave topical hydrocortisone cream. Case 3. A 4-month-old male baby with proportionate dwarfism and craniofacial defects presented with depigmented patches on bilateral knees since birth. On dermoscopy, we found absent pigment network, trichrome borders, satellite lesions, and microcoagulation. We made the diagnosis of congenital vitiligo in that syndromic baby, but no treatment was started as the baby was in poor general condition due to pneumonia. In our cases, milky white patches, chalky white patches, trichrome borders, mucosal vitiligo in mother in case 2, and wood slam findings and dermoscopy findings pointed in favor of congenital vitiligo. Comet tail appearance, tapioca sago appearance, trichrome borders, perifollicular pigmentation, they are markers of disease activity on dermoscopy. Therefore, the treatment was started in the first 2 cases, but not in the third case, as the baby was in poor general condition. Leukotrichia on dermoscopy indicates relative resistance to the treatment. Our other differential diagnoses were nevus depigmentosus, nevus anemicus, pityriasis alba, pityriasis versicolor, ash leaf macule, and P. waldism, which were ruled out based upon the clinical examination, wood lamp examination, um, diascopy, KOH microscopy, and finally dermoscopy. These were our references. Thank you.
Thank you, Dr. Shruti.
Welcome, sir.
Now the next presenter is Dr. Nitin Chabra. Dr. Nitin Chabra, please start your presentation.
Sir, am I audible?
Yeah, you are.
So just a second. Sir, are you able to see my slides and all?
Not yet.
Dr. Nitin Chabra, please share your screen.
Just a second.
Would you want me to present your presentation, share your presentation, and you'll speak about it?
Yes, ma'am, that's fine.
Right. Okay. Just give me a moment. Dr. Preeti ma'am, Dr. Raj, shall we begin the presentation?
चल ही नहीं रहा मेरा डॉक्टर साहिल का
Dr.
Yes, ma'am. Ma'am, you're not audible.
Dr. Rajraman sir, Dr.
Yeah. Yes.
Dr. Nitin, please start.
If you are not there, can we start the next one then?
Ma'am,
Sir, I'm Dr. Disha. I am getting a connection now.
Okay.
ma'am,
Are you
actually,
ready for presentation?
Yes, sir. Can you please share my screen?
Dr. Disha, your presentation is after Dr. Nitin.
Ma'am, I can't hear
ma'am,
you.
Sneha, ma'am, I'm not able to see my slides on the screen. That's why I'm waiting.
Dr. Disha,
Yes, ma'am.
आप भी mute कर लो. Your presentation will be after this presentation. Please wait. Okay.
Okay, thank you, ma'am.
Thank you.
Thank you, ma'am.
Dr. Nitin,
Yes, ma'am.
is the screen visible?
Yes, ma'am. Screen is visible.
Yeah, please start.
My slide is not on the screen. I mean, my seminar is not, my e-poster is not on the screen.
Yes.
It's not. Okay, just give me a minute then.
Hello, can you hear me, Sneha?
Is it?
Dr. Nitin, you can start.
Yes, sir. Good evening, sir. My name is Dr. Nitin Chabra. Today I will be presenting a e-poster on a case of a giant condyloma accumulator in an adolescent child successfully treated with electrofulguration. Abstract condyloma accumulata is an epithelioatrophic wart of anal and genital region caused by human papilloma virus type 6, 11, 42, 44, and 54. HPV is the most common viral sexually transmitted pathogen. It usually occurs in adults but may occur in children, often due to sexual abuse. We report a case of sexually acquired giant perianal condyloma accumulata in a 14-year-old male child successfully treated by electrofulguration with radiofrequency cautery under general anesthesia. Introduction. Condyloma accumulata is a anogenital wart, most commonly caused by HPV strain 6 and 11. Morphologically, there are four types of condyloma accumulata described as cauliflower type, papular warts, keratotic warts, and flat top papules. In pediatric population, the mode of transmission is both sexual and non-sexual. Treatment modalities include excisional biopsy, application of podophyllin, imiquimod, electrosurgery, injectable treatment with interferon or 5-fluorouracil. Persistence and recurrence are common in condyloma acuminata. We do a case report of a 14-year-old male patient presented to the Department of Dermatology with the chief complaint of asymptomatic massive cauliflower-like growth in a perianal area since last 4 months. The patient confessed to the history of a single unprotected penoanal sexual exposure with an acquaintance 1 year back. In a clinical examination, we see a hyperkeratotic verrucous tumor measuring 5 by 4 centimeter over the perianal area. Genitals were examined and there were no such lesions elsewhere on the body. Viral markers were non-reactive. All routine examination were within normal limits. In the skin biopsy revealed hyperkeratosis, papillomatosis, acanthosis of stratified squamous epithelium with coilocytic changes. Routine pre-anesthetic checkup was done. Bowel was prepared with enema. Electrofulguration done with cautery in the major OT. Post-operatively patient was managed by SITS bar, topical and systemic antibiotics, laxatives, NSAIDs, and the perianal wound healed in 2 weeks without any stricture formation. The discussion part, HPV are the most common viral sexually transmitted pathogen with subtype 6 and 11 more frequently associated with in sexually abused children. Buskell-Lowenstein tumor is a cauliflower-like locally invasive and progressive form of condyloma acuminata. It is usually benign, but in 1/3 of the cases can progress to the malignancy. The average incubation period in adults and adolescents is about 3 weeks to 8 months. In case of sexual abuse, most of the children do not show any evidence of physical trauma, thus making the evaluation complex. The DDs of condyloma acuminata are acrocodone, squamous cell carcinoma, condyloma latum. Treatment includes excisional biopsies, interferon or 5-fluorouracil, epinephrine gel implants, local application of podophyllin, imiquimod, curettage, electrosurgery, and CO2 laser ablation. However, we report a case of a giant perianal condyloma acuminata in a 14-year-old male boy treated successfully with electrofulguration. These are the references. Thank you.
Thank you, Dr. Nitin.
Thank you, sir.
Dr. Nitin, for your nice presentations. Let's move on. Our next speaker is Dr. Disha Chakrabarti. Dr. Disha, are you ready?
Yes, sir, I'm ready. I can't see my presentation.
Yeah, it's being uploaded.
Is the screen visible?
Yes, ma'am.
I just start the slideshow. Give me a minute.
Thank you, ma'am. Good evening, everyone. I, Dr. Disha, presenting a case report on transient neonatal hair loss in frontoparietal distribution. Introduction. In neonates, different patterns of transient hair loss have been identified, including the classical type, which is occipital alopecia, and neonatal type, which is frontotemporal alopecia. Herein, we present a case report of frontoparietal hair loss in 2-month-old female twins. The history is as follows. 2-month-old female twins born out of non-consanguineous marriage, prematurely born with cesarean section, presented with hair loss over the scalp. It started from last 1 month and increased gradually. There was no history of fetal distress or of obstetric or acquired trauma. The family history was unremarkable. On examination, there was decreased density of hair present over frontoparietal region of scalp in both the twins, with no cutaneous defect seen at the site of alopecia. There was no scaling, erythema, scarring, or induration on the alopecia areas. Exclamation mark hairs were absent. Hair pull test was negative. Nails were normal. Other systemic examination was within normal limit. Now coming to investigations. On dermatoscopy, there was decreased hair density with widespread thinning of hair, intermediate hair in the frontoparietal area, along with few thin curled hair. Scalp biopsy could not be performed as the parents did not give consent. Routine laboratory tests were within normal limits. Now discussion. First described by Brock in 1907, neonatal occipital alopecia is observed in the occipital region of infants 8 to 12 weeks postnatally. The new classification of transient neonatal hair loss includes neonatal type, which is rare, appears in the first 4 weeks of life in a frontotemporal pattern, and classical type is more common and appears 8 to 12 weeks postnatally with an occipital pattern. For many years, its etiology has been thought to be due to friction caused by neonate sleeping position. However, in recent years, it has been considered that it might be due to physiological hair shedding. In addition, it is thought that the condition is a synchronized telogen effluvium after a prolonged anagen phase, which begins in the prenatal period. Although neonatal occipital alopecia is relatively common, there have been very few epidemiological reports of this condition because it rarely shows severe symptoms that need treatment and also improves spontaneously. But in our case, the distribution of hair loss is frontoparietal, and to the best of our knowledge, this pattern of transient neonatal alopecia has not been described before. These are my references. Thank you.
Okay, thank you, Dr. Disha.
Thank you, sir.
Our next presenter is Dr. Shiman Yadav. A snail track ulcer as a sole manifestation of secondary syphilis. Dr. Shiman Yadav?
Yes, so, sir, I have not seen my slide.
Yeah.
Good evening, everyone. I'm Dr. Simon, and I'll be presenting my e-poster on snail track ulcers as a sole manifestation of secondary syphilis. Syphilis is an infectious disease which is sexually acquired or vertically transmitted. Oral lesions in secondary syphilis are common in association with general symptoms and cutaneous eruption. However, exclusive oral manifestations are uncommon, as seen in our case. The patient responded well to injectable benzathine penicillin with clearing of all lesions. Syphilis is caused by the spirochete treponema pallidum, which produces skin and mucous membrane lesions. In secondary syphilis, the mucous membrane lesions oval erosions or shallow ulcers of about 1 centimeter diameter in size, covered by gray mucoid exudate with an erythematous border. The patches usually arise bilaterally on the mobile surfaces of the mouth, although the palate, gingiva, tonsils, and very rarely the hard palate may be affected. In some cases, the oral lesions appear as white plaques or mucus patches, released together to form characteristic snail track ulcer. Cutaneous presentation of secondary syphilis includes generalized non-pruritic symmetrical papular eruptions, coppery in color with typical involvement of palm and a 47-year-old male reported to the Department of Dermatology with the chief complaint of multiple ulcers in oral cavity for the last 2 months. The ulcers were initially on the left lateral border of the tongue and later progressed to the buccal mucosa and soft palate. The patient also gave history of extramarital sexual relationship. On physical examination, the general condition was fair and the patient was afebrile. Intraoral examination revealed multiple irregular white to gray plaques ranging from 1 centimeter into 0.5 to 2 into 1 centimeter over the left lateral border of the tongue, lower labial mucosa and soft palate, surrounded by slight erythema and forming the snail track. No cervical and submandibular infection was present. The wife of the patient had no complaints, but local examination revealed multiple irregular non-pruritic brownish red maculopapular eruptions on the soles. VDRL of the wife was negative. Routine hemogram and biochemistry profile of the patient were normal. A KOS screening was negative. Samples were taken for VDRL, HIV-1, HCV, and HPS-AG testing. VDRL was positive in the titer of 1:128, and TPHA was further done, which came out to be positive. Secondary syphilis occurs approximately 2 to 12 weeks after the appearance of the primary lesion. The commonest features include non-itchy coppery red maculopapular rash involving the skin of the palm and soles. Other manifestations include condyloma lata, non-scarring moth-eaten alopecia, syphilitic paronychia, and oral mucosal lesions. 1/3 of the patients with secondary syphilis have oral mucosal lesions, which rarely are the only manifestation of the disease. The oral symptoms include mucosal patches, which release to form snail track ulcers, as present in our. Based on the clinical suspicion, VDRL was done, which came out to be positive, and further positive PHA confirmed the diagnosis. These are the references. Thank you.
Thank you, Dr. Simon.
Thank
So, our next and the last speaker is Dr. Sumit. He is presenting a case of chronic bullous disease of childhood in a 5-year-old child. Dr. Sumit, please start.
Yes. Good evening, everyone. Today I'll be presenting a poster on a case of chronic bullous disease of childhood in a 5-year-old child. A 5-year-old male patient presented to our OPD with complaints of multiple bullous lesions over the entire body since 1 month. There was no history of any drug intake prior to onset of symptoms. There was history of spontaneous healing, but a ring of blister would appear again around the healed region. So this was the patient. On examination, we saw multiple discrete round to oval polycyclic bullous lesions and crusts involving the trunk, both upper and lower limbs, face and scalp. The bulla or crust had raised beaded margins, giving the characteristic string of pearl or cluster of jewel appearance, which denotes appearance of new lesions around healed bulla. Oral cavity was spared. Investigations, hemoglobin was normal, TLC, and on DIF we saw linear IgA deposits at dermoepidermal junction. So on skin biopsy, we saw subepidermal bulla and neutrophilic infiltrate at the tip of dermal papilla. Based on clinical features and investigation, the diagnosis of chronic bullous disease of childhood was made. It is a chronic acquired subepidermal blistering disease of childhood that is characterized by linear deposits of IgA at epidermal basement membrane. It is a common acquired immunobullous disease in children with an onset usually before 5 years, and it frequently remits by 6 to 8 years of age. Vancomycin is the most common cause of CBDC, and our patient was started on tablet Dapsone 50 mg daily, and he showed significant improvement after 14 days with Dapsone therapy. Thank you.
Okay, thank you, Dr. Sumit. Dr. Preeti, you are still muted. So I think this session is over. So let's go back to Dr. Gaurav Bhaskar for the next session.
Hello, sir. Myself, Dr. Satveer Singh.
Dr. Satbeer.
Haan ji, sir. My presentation is not done, sir.
Doctors, it was only 5 presentation. Okay.
Dr. Sadbir, you are in free papers. These were e-posters.
Yes,
The free
ma'am. Thank
paper session will begin now.
you. Thank you.
Okay, okay.
Thank you all the presenters, and thank you chairpersons, Dr. Raj, Dr. Preeti.
Thank you.
Next session is free paper presentation. I would like to invite Dr. S.N. Bansal and Dr. Usha Kataria to chair the first session. Dr. Usha Kataria will be joining us in a few moments. Uh, Due to some technical problem, Dr. Usha has not joined. I think she has joined. Dr. Usha, kindly unmute yourself.
Hello, Dr. Gaurav.
Anji ma'am, good evening.
Hello.
Hello.
Good evening. Good evening. How are you?
Ma'am, shall we start with the session?
Yeah.
So, I would like to invite Dr. Usha Kataria to chair the session. Welcome, ma'am. For the first candidate for the free paper presentation, we have Dr. Sahil Sardana.
Okay.
He'll be speaking on giant scalp neurofibroma, a rare case presentation. Dr. Sahil, you can share your screen.
Yeah. I invite Dr. Sahil to present the case.
Is it visible now?
Hello, am I audible?
Yeah, you are audible, ma'am. Good evening. The screen is visible.
Hello, good evening. Yeah. Dr. Sahil, please.
The screen is visible, ma'am.
Yeah.
Yeah, okay. Hi, good morning, good evening, everyone. Myself, Dr. Sahil Sardana, and I am currently posted as senior resident in Kalpana Chawla Medical College and Hospital, Karnal, and I'm presenting my case on giant plexiform neurofibroma. It's a rare case. And let's first talk about what are neurofibromas. These are the tumors of nerve sheath origin and can develop in any peripheral encapsulated nerve of the body and may arise from Schwann cell, perineural cell, or fibroblast from the dorsal root ganglion to the terminal nerve branches.
Sahil, I'm sorry, I'm interrupting. Dr. Sahil, we are not able to see your PPT screen. Can you share your PPT screen, please?
Yeah, just
or would you want me? Yeah.
हाँ ये कनेक्ट कर दे.
Is it okay, ma'am, now? Hello?
Yes, Dr. Sahil. Your screen is visible. Kindly,
Yeah, is it
yes,
okay?
your screen is visible. Kindly switch on your presentation.
Okay. Yeah. Hi, good evening, everyone. Myself is Sahil, and I will be presenting my case on giant plexiform neurofibroma. First, let's talk about what are neurofibromas. These are the tumor of nerve sheath origin and can develop in any peripheral encapsulated nerve of the body and may arise from Schwann cell, perineural cell, or the fibroblast from the dorsal root ganglion to the terminal nerve branches. They can be broadly divided into three subtypes. These are solitary, diffused, and plexiforms. The plexiforms are the one which are diffuse masses with tortuous expansion along the branches of the parent nerve. As we all know that they are commonly but not always associated with neurofibromatosis type 1, that is NF1, and the solitary form occurs in those who do not have neurofibromatosis. Some authors consider solitary neurofibroma to be hyperplastic hematomatous malformation rather than neoplastic. Now let's talk about our case. There's a 53-year-old male presented to us with mild to moderately painful swelling over scalp since 2 years. And on examination, there was single
Dr.
well-defined.
Sahil, I'm sorry I'm interrupting you again, but your PowerPoint presentation is not active right now. Please switch on your PowerPoint presentation. What you're sharing is your document file. Please switch on, double click on the presentation.
Is it okay now?
No, it's not yet open. Double click on the document, na?
It is showing you are sharing the screen.
No, your screen is being shared, but what we are seeing is your document list. We are not able to see a PowerPoint presentation. Probably what you have done is now when you're sharing your screen, you have switched on, you have clicked on some other option. Go back to sharing your screen and select the option of screen. You have selected downloads ka option or maybe documents ka option. That is why we are only able to see the documents. You getting me?
I have done the same way.
You stop sharing, switch the share again, and then you select the option screen. Stop sharing.
Hello, screen is not visible.
Please share screen. Click on share screen.
the screen, please.
When you click on share screen, you will have multiple options.
Yeah.
Under one option, it is written screen. One will be written as document, one will be written as probably video, whatever is open on your computer, depending on that.
There are basic, advanced, and files.
No. That is on the right side. Na?
Yeah,
Extreme. Yeah, you have to click there.
I have clicked there and I am sharing the screen now.
Yeah, please share.
Is it okay, ma'am, now?
Yes, now you will have to switch on your PowerPoint. Yeah.
Is it okay?
Yes, please start.
Yeah. So the case study, we encountered a 53-year-old male presented to us with mild to moderately painful swelling over the scalp from past 2 years, and on examination there was single well-defined brownish black, non-tender, soft, boggy swelling over scalp starting from highest point of the pinna bilaterally and extending till the occipital region, measuring about 16 into 15 centimeter in its greatest dimensions. Now, as you can all see the picture, the starting point of the lesion is from the highest point of the pinna bilaterally and extending till the occipital region. Here is again the same patient, and as you can see, one noticeable point I want to highlight here is that the hairs are sparsely and very thin hair are present over this region as compared to occipital region. Now, it started as a small swelling 2 years ago, which started progressing and attained the present size. There is no history of any trauma and any birth trauma, and non-contrast CT head was done and was non-conclusive. So our main differentials were dermatofibrosarcoma protuberans, neurofibroma, dermatofibroma, lipidomatous scalp, follicular mucinosis, and leiomyoma. So we go ahead with fine needle aspiration, and features of spindle cell probably neural in origin were suggested, for which immunohistochemistry was performed, and CD34 and CD68, both of them were non-immunoreactive. A 4 mm punch biopsy was then obtained and stored in formalin and sent for histopathological examination, and which revealed well to ill-defined circumscribed non-epithelial neoplasm made of oval and spindle-shaped cell and filling up deeper dermis and subcutaneous. As you can see here, spindle-shaped cell are there, collagen fiber, mast cells are there, and between the cells of neoplasm are numerous thin fibrillary collagen fiber and mast cells. Thus, diagnosis of neurofibroma was made, and there was no other cutaneous evidence of neurofibromatosis or phacomatoses. Dermoscopy, we use DermLight third generation polarized mode and 10x magnification dermoscopy we did, and the findings we got were exaggerated pigment network broken at places by white dots, as you can see here, exaggerated pigmented network. The another finding was white dots representative of fibrosed follicular openings here, and the perifollicular brownish gray ring, as you can see here, multiple brownish gray rings perifollicularly were present, and various length of hair shafts spurting out from the edematous scalp, as labeled by me and the Dr. Nidhi Kamra as fountain sign. As you can see here, various lengths of hair shaft are spurting out from the follicles. So in the end, to conclude, we report a case of giant solitary plexiform neurofibroma as it's a rare case in its own kind. It usually found in the adult population, in young adult and the children's, and it's very, very rare in 50 plus patients. And the overlying skin was folded and hyperpigmented, and the lesion is described as having an appearance like a bag of worms. We also report dermoscopic finding of the case, as there are only 2 cases in literature in which dermoscopic findings are described. Thank you.
Thank you for the nice presentation.
Thank you.
I invite the second speaker, Dr. What is the name?
Dr. Bhumika.
Yes. Dr.
Senior
Bhumika. She is senior resident in Karnal Government Medical College. Dr. Bhumika, please.
Good evening, ma'am. Can you hear me?
Yeah, it's audible. Thank you.
Dr. Bhumika, would you like us to present your presentation, or will you be sharing your screen?
I'll be sharing my screen.
Okay.
Ma'am, is my screen visible?
Yeah, it's
Hello?
visible. You can start, please.
Yes, ma'am.
You're not audible. Hello. Hello.
Hello?
Dr. Bhumika, you are not audible.
Yes, ma'am.
You are not audible. You can
Yes, ma'am.
start.
Just a minute, ma'am.
Okay, okay.
Please share the presentation you have downloaded. Hello, Sneha ma'am.
Dr. Bhumika?
Yes, ma'am. Can you please start the presentation that you have downloaded?
I'll be sharing your presentation, Bhumika, but you will have to speak live. Okay?
Okay, ma'am.
Okay.
Good evening, everyone. I'm Dr. Bhumika Chaudhary, working as Senior Resident in Department of Dermatology at Kalpana Chawla Government Medical College, Karnal. Today, I am presenting my paper on a case report of homeopathic arsenicosis. Arsenicosis is emerging as a global health problem, especially in Asian countries. It is characterized by cutaneous and internal organ involvement due to prolonged ingestion of arsenic above permissible amount. It can occur either due to contaminated drinking water or by intake of some Ayurvedic or homeopathic medicines which contain arsenic. Though the diagnosis can be made clinically, estimation of arsenic levels in drinking water and urinary arsenic levels are important diagnostic tools. Here we report a case of arsenicosis following consumption of homeopathic drugs. A 43 years old male patient came to our OPD with complaints of punctate keratotic lesions over palms and soles, whitish discoloration of nails, and mottle pigmentation over trunk since last 2 years. Patient was apparently alright 2 years back when he started developing punctate keratotic lesions initially over both palms, which gradually progressed to involve both soles. He also gave history of development of light colored patches over dark pigmented background since 2 years, and he also gave history of whitish discoloration of all 20 nails. There was history of consumption of some homeopathic and Ayurvedic medications on and off since last 10 years. There was no history of generalized weakness, nausea, vomiting, breathing problems, or paresthesia. There was no history of diabetes, hypertension, tuberculosis, or cough or asthma, and there was no history of similar complaints among family members. On, um, on examination, there were discrete, multiple 2 to 4 punctate hyperkeratotic lesions seen over both palms and soles, and mottled hypopigmented macules with underlying hyperpigmented patches were seen over chest, back, and bilateral upper extremities. And there was total leukonychia involving all 20 nails. In this photograph, mottled pigmentation can be seen over the chest of the patient. And these are multiple bilateral punctate hyperkeratotic lesions seen over bilateral soles, and this picture shows total leukonychia involving the fingernails. Now, lab investigations, there was pancytopenia, serum bilirubin level were mildly raised, and serum amine transferases levels were also mildly elevated. Chest X-ray, ECG, ultrasound abdomen were normal, and urinary arsenic levels of the patient were also normal. On histopathology, sample showed fairly circumscribed focus of
Arsenic used therapeutically in homeopathic medicines can cause clinical toxicity if the medications are improperly used. So, preventive measures like cessation of exposure is of utmost importance. Patients should be advised to stop drinking arsenic contaminated water, and it itself helps in regression or improvement of skin manifestations, weakness, anemia, neuropathy. The role of nutrition and antioxidants in preventing the onset of symptoms of arsenicosis is also important. High protein diet possibly helps in clearance of inorganic arsenic by increased methylation. Thus, people should be urged to take food containing proteins in good quantity, either from animal sources or if it is not available from vegetable sources like pulses, soya beans, wheat, etc. Beneficial effect of oral supplementation with vitamin A in the treatment of cutaneous arsenicosis is described, which resulted in partial regression of hyperpigmentation and hyperkeratosis of palms and soles. Oral retinoids like acitretin, E-tretinoin have also been used. Supportive therapy like keratolytic agents like 5 to 10% salicylic acid and 10 to 20% UV-based ointment for hyperkeratinization serve as palliative measures. Our patient was also given tablet acitretin 25 mg along with salicylic acid and urea-based ointments, which resulted in partial regression of keratotic lesions. The persons affected need to be followed up at regular intervals to detect the onset of cancers, if any, at the earliest. Thank you.
Thank you, Dr. Bhumika, for the nice presentation.
Thank you, presenters, and
thank you, ma'am.
thank you, Dr. Usha Kataria.
Okay, thank you, Dr. Gaurav.
Yeah. For the next session, I would like to invite Dr. Kiran Bajaj as chairperson. Dr.
Hello,
Kiran.
good evening, everyone. Yeah, good evening.
Welcome, Dr. Kiran.
Thank you so much, Dr. Gaurav.
Dr. Sadbir Singh, please come online.
Yes, ma'am.
Will you be sharing your screen or do you want us to?
Ma'am, I will share my screen, ma'am.
Okay.
Ma'am, I am audible.
Hello. Yeah, you are audible. There are certain breakouts in the voice, but yes, we can hear you. Yeah. Hello. Welcome, Dr. Sadbir.
Yes, ma'am.
Yeah. So Dr. Sadbir is a third-year resident in PJ and Rohtak, and he's going to present a free paper on efficacy and safety of trichloroacetic acid 30% in mild to moderate asthma, a comparative study. So please start.
Ma'am, am I audible, ma'am?
Yeah, you are audible.
Ma'am, my screen is
No, Dr. Sadbir, your screen is, your PPT is not being seen. Please share your screen.
Yes, ma'am.
Click on the share screen option.
Yes, ma'am.
There is an option of sharing screen again in it. There's a word called screen. Please click on that.
Yes, ma'am.
Dr. Sadbir, please click on slideshow. Please. There, towards your right hand corner, there is an option for slideshow. Please click on that. Right hand extreme, you're able to see. Dr. Sadbir, shall I share the screen and will you please give us the presentation? Is that okay? You are muted, Dr. Sadbir. Dr. Sadbir, you're muted. Please unmute. Yeah.
Ma'am, is it visible my screen, ma'am?
Your screen is visible, Dr. Sadbir, but you have to click on the slideshow. Switch on your, double click on your presentation. Right hand side. Yeah, just beside that. The icon beside that. Towards your right.
Is it okay, ma'am?
It's open. You will have to switch on the slideshow, right? Dr.
Yes, ma'am.
Sadbir?
Yes, ma'am.
Please click on slideshow. Right, very good. Please start.
Ma'am, good evening, everybody. Today my topic is clinical efficacy and safety of 25% trichloroacetic acid pills versus 30% salicylic acid pills in treatment of acne, mild to moderate acne vulgaris, a comparative study, ma'am. Acne vulgaris is chronic self-limiting inflammatory disease of pilosebaceous unit, occur mainly on face, mid-chest, back, shoulder, and upper arm. Type of lesions are non-inflammatory or comedones, and inflammatory lesions are papules, pustules, nodules, cyst, and abscess. Therapeutic approach in acne vulgaris are topical are retinoids, azelaic acid, benzoyl peroxide, topical antibiotics, and orals are antibiotic, hormone isotretinoin. Procedural are chemical peels, comedone extraction, microderma abrasion, cryotherapy, radiofrequency, and ultra-pulse CO2 laser. Chemical peels in acne vulgaris are salicylic acid peels, Jasner's peels, TCA peels, mandelic acid peels, azelaic acid peels, lactic acid peels, pyruvic acid peels, and tretinoin peels, ma'am. Trichloroacidic acts by coagulation of protein by the minimal erythema, but no frosting up to white solid frost, which is depend on depth of peels, which is directly proportional to concentration of TCA. Salicylic acid acts by expulsions without any inflammatory changes and have strong comedolite effect and promote desquamations. And aim and object is to compare the clinical efficacy and safety in the form of decrease of Michelson acne scores and the side effect of 25% TCA acid peels versus 30% SA peels in treatment of acne vulgaris. Inclusion criteria: patient taken mild to moderate facial acne vulgaris, no taken treatment for at least 4 weeks prior to studies, and willing to consent for this study. Pregnant and lactating mothers are excluded. Hypersensitive to formulations used in study. History of hypertrophic scar and keloid formations, photosensitivity and anelastic extraction, and presence of any other cutaneous and systemic disease patient are excluded from the study. Total 50 patients were enrolled and 25 patients in each group. Total 6 sessions performed at 2 weeks interval for 12 weeks. Post-auricular test peels performed prior to start therapy. Patient made to lie down with head elevated at 45-degree angle, instructed to eye closed and ear plugged with cotton. Lateral medial canthi oral commissioners, lips, and alar nasal grooves protected by thin layer of Vaseline. Forehead treated first, followed by malar and chin area. Endpoint of TCA peels: white frost with background erythema, SA peels pseudo frost. In clinical evaluations by devised by Michelson, in which severity index given to comedone 0.5, papule 1, pustule 2, inflate 3, and cyst 4. And grading system defined by M.A. Tutkani and SSM Vaishampian, in which grade 1 and grade 2 acne vulgaris have mild to moderate, which have comedones, papules, and few pustules. Michelson acne score will be calculated by patient number of comedone into 0.5 plus number of papule into 1 and number of pustule into 2. Assessment of acne lesions will be done at baseline and at each visit, 2nd, 4th, 6th, 8th, 10, and 12 weeks, and side effects recorded during and after the procedures, And clinical photographs will be taken front, right, and left view of each patient. Statistical analysis comparison within the group by unpaired t-test and comparison between two groups by paired t-test, and p value of 0.05 or less was considered as significant. This is the improvement in patient 1 in both groups. This is the patient 2 in both groups, and this is the patient 3 in both groups. Observation are both the group were comparable in terms of age, duration of disease, baseline mean Michelson score. Mean Michelson acne scores will be decreased, was decreased 146.78 to 69.12 in group 1 and 146.2 to 65.96 in group 2, and the difference in both groups is statistically not significant. If the improvements are the good, was good and fair in both groups, and no patient have poor improvement, and the difference between both groups are statistically not significant. In the term of side effect, term of erythema and PIH and burning and stinging sensations, more towards the TCA groups, and burning and stinging sensations difference in both groups was statistically significant. Improvement in Michelson acne scores, trichloroacidic equal to salicylic acid, and in the side effect, trichloroacidic acid have more side effect than the salicylic acid. Both trichloroacidic acid and salicylic acid pills showed significant improvement, but there was no statistically significant difference in their efficacy. In terms of safety and tolerability, 30% salicylic acid pill was better tolerated than 25% TCA pill. Thank you.
Thanks, Dr. Sukhdeep, for a nice presentation. So, may I take this opportunity now to invite Dr. Rupinder Kaur. Are you there, Dr. Rupinder? Hello.
Hello.
Dr. Sadhvi, please stop sharing your screen. Dr. Rupinder Kaur, would you like to share us your presentation? Or...
Yeah. Hello, Dr. Rupinder.
Yes, ma'am.
Hello.
Good evening, ma'am.
Good evening, Dr. Rupinder. So she's a third-year resident in PGIMS Rohtak. So today she'll enlighten us through a free paper presentation on recent advances in acne scar management. So please, Dr. Rupinder, carry on.
Yes, ma'am. I'm sharing, ma'am.
Yeah.
Dr. Rupinder, if there's an issue with your presentation, shall I share your presentation on screen?
Yes, ma'am. I'm not able to share. Can you please share?
Yeah, we'll do that. We are running short of time, and please make sure that you're within your 5 minutes.
Yes, ma'am. Am I audible, ma'am?
Yeah, you're audible. Please carry on.
Good evening, everyone. The topic of my presentation is recent advances in management of acne scar. As we all know, acne is a common and complex inflammatory disease of the pilosebaceous unit, mainly affects the face. Acne scarring is an unfortunate sequel of acne. Post-acne scarring have a significant negative impact on the quality of life by causing cosmetic problems and psychosocial dysfunction. Next slide, ma'am. Acne scars
is classified into atrophic, hypertrophic, and macular scar. Atrophic is the most common type, constitute 80 to 90% of the acne scar, which can be further classified into ice pick scar, box scar scars, and rolling scars. Management of acne scars have also always been a therapeutic challenge, but recently treatment of post-acne scarring has become easier with newer modalities. Management of acne scars should follow an algorithmic approach that targets each component of scarring. Each scar and each patient must be treated individually on their merits according to the patient characteristic as well as the scar characteristics. Next slide, ma'am. Treatment options can be categorized into non-energy based, topical, as well as laser, and as well as surgical. Energy based classified into lasers and microneedling. Classification of surgical procedure for acne scars are chemical agents that include chemical peel, TCA cross, botulinum toxin. Lasers and energy based include radiofrequency microneedling, ablative and non-ablative lasers. Surgical based include subcision and punch techniques. Mechanical trauma based include dermabrasion, microdermabrasion, microneedling, and volumetric remodeling. Platelet-rich plasma, leukocyte-rich plasma, cell-based surgical procedures. Others are autologous fat transfer and temporary, permanent, and semi-permanent fillers. Topical therapy. Among the topical agent, tretinoin, adapalene, and tazarotene exhibit anti-inflammatory activity, which would appear to decrease the development of acne scarring. In the studies done, adapalene 0.3% gel and topical tazarotene 0.1% gel has shown efficacy for the treatment of acne scars. Chemical peel is a procedure in which caustic chemical substance is applied to destroy the layer of skin, which induces the repair mechanism of the epidermis and dermis. These are the various peels used in acne scars. TCA cross is serial local application of high concentration TCA varying from 35 to 100% with a wooden applicator to the scar. It is useful in all type of acne scar, including ice pick scars. Dermabrasion is sequential removal of the skin layer to a desired level from the epidermis to dermis. Microdermabrasion only removes the outer layer of the epidermis. Chemoabrasion is when chemical peeling agent is combined with microdermabrasion. Microneedle radiofrequency fractional. Radiofrequency disrupts the dermal fibrotic strand and trigger collagen remodeling. It is useful in atrophic acne scar as well as open pores. Microneedling or collagen induction therapy is a minimal invasive procedure that involves superficial and controlled puncturing of the skin by rolling with miniature fine needles. Instruments can be used as manual derma roller or electronic derma pen. It's useful in all type of atrophic acne scar. Best results are seen in rolling type of scars. Lasers and light sources. Thermal injury delivered by laser lead to stimulation of dermal fibroblasts, which initiate new collagen and elastin production. Different type of lasers used are ablative and non-ablative, that include fractional as well as non-fractional laser. Subcision is most useful for rolling scar. It is a simple technique for the elevation of depressed tethered scars by the introduction of sharp needle beneath the scar, which break the fibrous adhesions and lifts the scar up. Elliptical excision is done for the scar more than 3.5 mm width. Punch technique include punch excision, grafting, elevation, and flotation technique. It is useful for the scars up to 3 to 4 mm that include deep ice pick and larger ice picks, deep box scar and larger ice pick scar that extend to deep reticular dermis. Autologous fat grafting is useful in case of lipoatrophic acne scar. It has the advantage of supplying adipose-derived stem cell, which have an important role in the regeneration of collagen. Fillers are used to augment soft tissue by injecting a filler underneath, particularly in soft atrophic, rolling, or box scar. Filler can be classified into temporary, semi-permanent, and permanent filler. Polymethyl methacrylate is the only US FDA-approved filler for the treatment of atrophic acne scars. Platelet-rich plasma is an emerging therapeutic tool in which patients' own concentrated platelets are used to promote wound healing. It is mostly used as an adjunctive therapy to other treatment modalities. Newer and experimental treatment include autologous non-cultured dermal cell suspension. In atrophic acne scar, as dermis is low due to inflammation, therefore dermal suspension could be an ideal volume replacement. Autologous fibroblast culture injection is the only FDA-approved therapy for aesthetic use. It can be used for acne scars, but its onset of effect is slow and gradual. Jet volumetric remodeling is a needle-free technology. It accurately delivers kinetic energy and healing compound at a high speed simultaneously via a tiny entry point in the epidermis. The particle acting as nanobullet disperse in the dermis to create a microtrauma which promotes neocollagenosis. Radiofrequency subcision is a modification of subcision. It has the advantage of decreasing the chances of post-operative bleeding and hematoma formation. The fibrotic strands get cut with ease without any mechanical force. Now, this is a figure showing the management of acne scar based on the individual scar types, including ice-split, box scar, rolling, linear, hypertrophic scars. Next slide, ma'am. Take-home message: early treatment of active acne remains only the best way to prevent or limit the acne-related scarring. Complete resolution of acne scar is a challenge. Combining different modalities produce better outcomes. The ultimate goal of any intervention is for improvement, not for a total cure of perfection. Single, multiple treatment or combination therapy may be required. These are my references. Thank you.
Thank you, Dr. Rupender. That was a short and crisp presentation, keeping in mind the shortage of time. So thank you so much.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Dr. Vijay Kumar Mehra, are we audible to you?
Yes, ma'am. Yes, ma'am.
Dr. Vijay, shall we share your presentation or will you be sharing your screen?
There are echoes on the screen. Already video is played from Dr. Upender. That is, I am listening to that one only.
So that video is already over. Dr. Rupinder Kaur has finished her presentation. It's your presentation now. Do you want me to share screen?
Actually, she is still audible to me. I'm listening.
Probably your internet is a bit slow, sir.
Am I audible, ma'am?
Yes, you are audible.
Does my screen is visible to everyone?
Yeah, this is visible. So, Dr. Vijay Kumar Mehra, so he is a third-year resident at PGIMS Rohtak. Today he will be kind of presenting a study of metabolic syndrome in male patients with early onset androgenic alopecia.
Ma'am, please don't play any audio video at your part. I'm just no, ma'am. I'm sharing my screen. I'm sharing my screen.
Yeah, most welcome. Please do.
Am I audible, ma'am?
Yeah, you are audible. Please carry on.
Okay, ma'am. Okay, ma'am. Should I start?
Yeah, you can start.
Yes. No, ma'am. No, ma'am. Don't share any screen. I'm sharing from my end only. So should I start?
Yeah, you start speaking. We'll see later on if there's any problem. Yeah, please start.
Everyone. I'm Dr. Vijay Kumar Mehra. I'm presenting the study of the metabolic syndrome in male patients with early onset androgenetic alopecia. Background. Androgenetic alopecia. AG is a common cause of non-cicatricial alopecia. The onset of AG occurs before the age of 35 years. Is considered as early onset AGA. The hormonal, genetic, and environmental factors play important role in its etiology. The dihydrotestosterone, a DST, is a metabolite of testosterone, plays a casual role in its development. The patterned hair loss over the crown is an essential clinical feature of balding in both the sexes. Shorter and finer hair progressively replace terminal hair. The metabolic syndrome is a clustering of risk factors that are metabolic in origin and are associated with risk of cardiovascular disease. It includes the abdominal obesity, atherogenic dyslipidemia, elevated blood pressure, raised blood glucose. Over the last few decades, many studies across the world have indicated comorbidities like diabetes, hypertension, lipid abnormalities in patients with early onset AGA. The prevalence of the metabolic syndrome is 15 to 25% in general population. The recent studies have found higher prevalence of the metabolic syndrome in patients of early onset AGA as compared to general population. Aim and objective of the study: to study the association between the metabolic syndrome and early onset AGA in male patients, and to study the correlation of the metabolic syndrome with severity of early onset AGA as per Norwood-Hamilton classification. Materials and methods. This was an observational, non-international cross-sectional study consisting of 100 clinically diagnosed male patients of early onset AGA, 100 age-matched controls attending the outpatient department of dermatology, PGMS reality as per South Asian Modified National Cholesterol Education Program, adult treatment panel 3 criteria.
Please take care of your microphone. It is moving. Your voice breaks out in between.
Okay,
please take care of your microphone.
Of AGA was assessed as per Norwood Hamilton grading. The inclusion criteria.
the new clinically diagnosed male patients of the early onset AGA who have not been started with any treatment for AGA between age 18 and 35 years. Exclusion criteria. The patient with other type of alopecia like alopecia areata, scarring alopecia, the patient with skin disease known to be associated with the metabolic syndrome, with early of the diabetes, hypertension, and familial hyperlipidemia. The patients receiving hormone replacement therapy with testosterone and on corticosteroid therapy. Patient on the drugs that are known to cause hyperglycemia, hypertension, and hyperlipidemia. The patient with history of smoking and alcohol consumption. An informed consent was taken. Data like gender, disease duration, history of smoking, and alcoholism, concomitant. Okay, ma'am. Concomitant medications, past medications, weight, waist circumference, and blood pressure was systematically recorded on a standard performer. The waist circumference was measured at the level of midpoint between lower margins of the last vertebral rib and the top of iliac crest at the end of normal expiration as per WHO guidelines 2008. Blood pressure was recorded as the average of the two measurements after subject rested for 5 minutes. The severity of AG was assessed by the Norwood Hamilton severity grades. Results. Prevalence of the metabolic syndrome among two groups. A total of 8 patients in group 1, that is cases, and the 2 patients in group 2, that the controls, as having found to have metabolic syndrome. On statistical analysis, the difference between the two groups was found to be statistically significant. P-value was 0.05. Frequency of individual components of metabolic syndrome among two groups. There was systolic blood pressure and the diastolic blood pressure was statistically significant, while the other parameters like circumference, fasting blood sugar, SDL, fasting triglycerides were statistically insignificant. Prevalence of metabolic syndrome among AG according to severity grades. Out of total 54 cases of grade 2, we were found to have metabolic syndrome, and out of 36 in grade 3 found to have metabolic syndrome.
Excuse me, Dr. Vijay.
Hanji, ma'am.
Your
Yes,
microphone is moving.
Yeah, it is causing a lot of.
Voice is not clear.
Dr. Vijay, please check your microphone. Maybe it is not properly in place.
Out of 10 patients in grade 4, 1 was found to have metabolic syndrome. The comparison of individual components of metabolic syndrome only the systolic blood pressure was found to be statistically significant, while the other parameters were statistically insignificant. The p-value of SBP was 0.03. Comparison with the previous clinical studies. While all other studies conducted by the Tilwani R. Mohammed et al., Dharmkumar K.C. et al., Chakravarti S. et al., and Bangar Harmeet Singh et al., in which all the studies, the metabolic syndrome was significant in the all in the cases of AGA as compared to yes, ma'am. Okay, ma'am, I'm adjusting it. Am I audible, ma'am, now? Am I audible clearly, ma'am?
You are audible in bits and pieces. In between, your voice just vanishes.
The difference between the results of various studies can be partly explained by the geographical, ethnical, and difference in the applied diagnostic criteria of metabolic syndrome. Conclusion. The results from the present and previous studies support the possibility of the benefit of the regular screening for the metabolic syndrome and its component among all patients of early onset AGA in order to reduce their risk of secondary diabetes and cardiovascular disease. Need for counseling of the patient regarding healthy dietary habits and regular exercise and community-based program for health awareness and life modification. Limitation. The major limitation of present study was a small sample size and time-bound study. These are my references. Thank you.
Thank you, Dr. Vijay.
Thank you, Dr. Kiran.
Thank you so much, Dr. John.
Thank you, all the presenters. We are running short of time, so we'll take the free papers, rest of the 5 free papers after the next session. The next session will be the scientific session. For that, I would like to welcome Dr. Anil Ganju to moderate the session on seborrheic dermatitis. Dr. Anil Ganju, are you there? So I think there is some time for Dr. Anil Ganju to join the session. So we'll be starting the next session on seborrheic dermatitis, current and emerging treatment options. The session will be moderated by Dr. Anil Ganju. Dr. Sneha, kindly share the CV of Dr. Anil Ganju here, if you can. Dr. Anil Ganju is a senior consultant dermatologist and laser surgeon. He is recipient of prestigious Dr. Sardari Lal Memorial Lifetime Achievement Award, awarded by IADVL DSB, ET Inspiring Dermatologist of the Year 2019, Das Dermatologist of the Year 2018, IADVL President's Appreciation Award 2017, Heads of Department of Dermatology in several prestigious Delhi institutions, and President SAC AAD, past Vice President IADVL National and past President IADVL DST. Hello, Dr. Anil.
Hi. How are you, Dr.
Hi,
Gaurav?
sir. Fine, sir. Fine.
You good to see you.
Sir, shall I start?
Yeah, please. I'm sorry.
Yeah. No, sir. So I welcome Dr. Anil Ganju to moderate the session on seborrheic dermatitis, current and emerging treatment options. Dr. Anil Ganju is a senior consultant dermatologist working in Delhi. He has achieved many different awards. He is a recipient of prestigious Dr. Sardari Lal Memorial Time Achievement Award, awarded by IADVL DSP, ET Inspiring Dermatologist of the Year 2019, Das Dermatologist of the Year 2018, IADVL President's Appreciation Award 2017, Heads of Department of Dermatology in several prestigious Delhi institutions, and he is President SAC AAD, past Vice President IADVL National, and past President IADVL DSP. Welcome, sir. Sir, now you can introduce your panelists for the discussion.
Thank you very much, Dr. Gaurav. I somehow do not have the slides of my panelists. Somehow, either they were not sent to me or I have missed them out. So I'm going to introduce them as far as I know them. I know them very well at heart. Okay, so today's session is on something that is not discussed often, but is always around: seborrheic dermatitis. We have not had sessions, we have not had conferences on seborrheic dermatitis, but we see it always. Almost every clinic you will see seborrheic dermatitis, and you treat it. But there are times when we need to look at different therapies for this difficult disease. There are patients who will not respond. I had a patient who I wanted desperately to do PRP on, but his seborrheic dermatitis never ever resolved, and I could not go and do his PRP. So here we are to look at this sometimes difficult situation, which needs to be looked at and which needs to be discussed. And there are newer therapies that are coming in this difficult disease also. Today we are going to have an overview of this condition and how things have evolved. What is the therapeutic armamentarium that we have for this disease, and Dr. Sumit, a budding consultant dermatologist from Gangaram Hospital, Delhi, and Skinnovation Clinics, Delhi, is with us. Dr. Sumit is an alumni of MAMC, Delhi, and I am fortunate to have him as my team at Skinnovation. He's going to deliberate on the subject and give us an overview of the disease and how we have evolved as far as the disease is concerned. So over to Sumit without wasting any more time.
Thank you very much, sir. First, I would also like to thank IADVL Haryana State Branch. It is indeed a proud moment to connect once again to the state where my roots are from. So, without further delay, I'm going to start delivering my presentation on seborrheic dermatitis, an update on pathogenesis and treatment. I hope I'm audible.
Yeah, you are.
Yeah, okay. So seborrheic dermatitis, as we all know, is essentially a chronic endogenous eczema. It is classified as an endogenous eczema, typically affecting scalp, face, the eyebrow region of the face, the nasolabial folds, the beard region, the retroauricular folds, and also the non-facial areas of chest, back. It can occur as a petalloid in a petalloid morphology, or as a psoriasiform morphology as well as pityriaciform morphology as well. It can also occur at folds of skin like the groin folds or the inframammary folds, and often dandruff and seborrheic dermatitis are considered synonymous, although dandruff is just scaling or flaking of scalp, which it can be due to any cause. Mostly it is due to seborrheic dermatitis. It's the mildest sort of clinical manifestation of seborrheic dermatitis. But seborrheic dermatitis, particularly, some authors try and use this term when flaking is associated with erythema, pruritus, or sometimes oozing, crusting, and sometimes also pustules. Worldwide prevalence of seborrheic dermatitis is 3 to 12% of population, 1 to 2% in general population, and it is very common in immunocompromised patients. In HIV patients, according to certain data, it is as common as 40 to 80% also. And mostly it starts in children, less than 5 years of age. There is an infantile variety also, and prevalence peaks during infancy and then steadily decreases with age. Etiopathogenesis of seborrheic dermatitis has three important pillars. First is the sebaceous gland activity, which is slightly more in these patients, which can lead to more malassezia colonization. So basically, sebaceous glands, they secrete lipids onto the skin surface. If that lipid is more, malassezia colonization occurs in areas where sebaceous gland the density and the lipids are more. Lipases secreted by malassezia results in generation of free fatty acids, particularly oleic acids and lipid peroxidases that activates the inflammatory response. The immune system, our immune system, which generates this inflammatory response, generally has this inflammasome consisting of IL-1 alpha, IL-1 beta, IL-2, IL-4, IL-6, and TNF alpha, which leads to, apart from erythema scaling, also keratinocyte proliferation and differentiation, which leads to scaling and hyperkeratosis also at certain areas. And this also results in skin barrier disruption, which is more apparent as erythema, pruritus, and scaling. So there is this individual susceptibility of the host, which leads to more vulnerability to develop this kind of rash. And individual susceptibility consists of epidermal barrier dysfunction, genetics, obviously, immunity, as we all know, we've seen before in immunocompromised patients, it is more probably due to more malassezia colonization. Certain bacteria also play some important role, like Staphylococcus aureus, Strep epidermidis. Neurogenic factors, it is known to be found more in patients of Parkinson's disease, post cerebrovascular accidents or stroke patients, and also patients who are malnourished, both malnourished and obese patients, which is also a type of malnutrition, are known to have more seborrheic dermatitis. So this is how the at the molecular level, the pathogenesis of seborrheic dermatitis looks like. Sebocytes, lipids are secreted onto the skin surface. Malassezia, which secretes lipases, would break down that lipids into irritating unsaturated fatty acids like oleic acids. These irritating fatty acids and malassezia species induce dendritic cell maturation, and through toll-like receptor stimulation and islet production is increased by keratinocytes, and there is an inflammasome which is activated, consisting of all these cytokines, which leads to neutrophil and lymphocyte migration and NF kappa beta activation, which leads to more epidermal proliferation and differentiation, keratinocyte proliferation and differentiation, and also epidermal barrier dysfunction. Genetics play an important role. There are, in fact, 11 genes isolated on 11 genetic mutations isolated on 6 different gene foci listed here. They particularly have to do with our immune response to fungal infections, and also certain enzymes deficiency or certain important protein deficiency, which leads to epidermal barrier dysfunction, which lead to development of seborrheic dermatitis. Androgenic activity, the prevalence of seborrheic dermatitis is found to be far more in males, and also in women with hyperandrogenism, like women suffering from PCOS. It is known to be found more. So definitely androgens play an important role in more sebaceous gland activity and lead to the pathway of seborrheic dermatitis. Increased cosmetic use in certain studies by females have also have also shown to be increasing seborrheic dermatitis, particularly in India, where people are obsessed with applying different kinds of oils on scalp. Although oils are known to sort of alleviate the epidermal dysfunction to a certain extent, but mostly if they also are consisting of that kind of fatty acids or that kind of substrate which the lipases can break down and form more oleic acids that can lead to more seborrheic dermatitis. Immunological factors, as we discussed, may lead to more colonization by malassezia in susceptible individuals and can lead to more seborrheic dermatitis. Neurological factors, due to some identified and some not so very well identified neurotransmitter dysregulation, can also lead to this sort of pathway, this sort of inflammatory response in people suffering from Parkinson's typically, and also people suffering from Alzheimer's, as well as people suffering from cerebrovascular accidents. Although some workers also believe this has to do with decreased sort of grooming in such patients, which can lead to seborrheic dermatitis. Dietary factors, it is known that in taking more of high glycemic index food, as well as food which leads to more subsistence of yeast organisms like bread, cheese, and everything, food or products like this, and decreased fiber intake can lead to flares of seborrheic dermatitis. So this is the clinical correlate of different pathogenic mechanisms which lead to which are seen in seborrheic dermatitis. For example, when there is increased inflammation, it is seen as more erythema, itching, heat, burning, stinging sensation. If there is more proliferation, it is seen as more flaking. If there is more barrier disruption, it is perceived as more dryness and or tightness by patients. So this is how it is. The treatment principles actually tries and counters these different pathogenic mechanisms like malassezia. To decrease malassezia number and colonization, antifungals typically are used, like zinc pyrethrione, selenium sulfide, ketoconazole, and other antifungals. Grooming obviously helps in removing the lipids which are secreted by sebaceous gland more frequently, so that they do not undergo the degradation by lipases. And also sebum suppression can be done by using, rarely although not very commonly, by using systemic retinoids. Hyperproliferation can be countered by anti-proliferatives such as coal tars and anti-inflammatory agents like topical steroids, as well as non-steroidal anti-inflammatory agents like bisabolol and others. Flakes, if they are formed, they need to be removed by using keratolytic agent like salicylic acid, or if there is sort of a film formation, although it's not considered as typically as the biofilm, but if there is thick scales, the whatever medication that we are using, that will not penetrate and reach the active site. So it's a sort of a film formulation. So we need to use salicylic acid and sometimes also emollients to loosen out those crusts. So treatment algorithms, mostly in guidelines, have been suggested on the basis of site of seborrheic dermatitis, non-scalp, scalp and hairy areas, and infantile seborrheic dermatitis. So if we talk about non-scalp areas, if it's a mild seborrheic dermatitis, mostly just topical antifungals or non-steroidal agents which are anti-inflammatory and also have antifungal properties, such as tea tree oil or bisabolol. They help in reducing this sort of symptoms. Improve noticed. It is extended until remission. If there is no improvement, then we need to combine both topical antifungals as well as anti-inflammatory agents. If not so, then low potency topical steroids can be given for 2 weeks. And if there is improvement, then it can be extended. If there is no improvement, the recommendation is to switch to topical calcineurin inhibitors. If it is moderate to severe, straight away mid-potency topical steroids with or without topical antifungals are advised. If there is improvement, it is supposed to be extended for 2 weeks. If no improvement, systemic antifungals need to be added. If there is no improvement, then it is recommended to switch to topical calcineurin inhibitors. So these are different agents which are used, like topical antifungals. Mostly the agents which are used are ketoconazole, clotrimazole, cycloperoxoleamine. Anti-inflammatory antifungal products are bisabolol, pyroxoleamine, glyceryl, glyceric acid, topical corticosteroids, hydrocortisone. Mostly class 1 is used on facial area, on face. Topical calcineurin inhibitors, which is not US FDA approved, but still is recommended in certain guidelines like pimecrolimus and tacrolimus. And in moderate to severe seborrheic dermatitis, class 2 topical steroids like fluticasone or mometazone can be used. Systemic antifungals like itraconazole or fluconazole are used primarily. Terbinafine, although recommended, but it does not have significant activity against yeast fungi. For scalp and hairy areas, if it is mild, antifungal shampoo or pyroxone, oleomine shampoo or selenium sulfide or ZPTO shampoos are supposed to be used. If there is improvement, it is suggested to be continued. And if there is no improvement, a weak to moderately potent topical corticosteroid can be used for to about 4 weeks. In moderate to severe, again, there is combination of antifungal as well as corticosteroids. So if there is no improvement, it is recommended to add systemic antifungal. So basically, the overview of both the algorithms is similar. So this is a similar sort of agent chart of agents which are used. For infantile seborrheic dermatitis, topical antifungals along with emollients, if there is thick crusting on the scalp, can be used. Anti-inflammatory antifungal products can also be used. And for non-scalp areas, topical antifungals or topical corticosteroid up till hydrocortisone or destonide can be used. Apart from these guidelines, what in addition most of us sometimes use are, if there is a very sort of severe flare, we sometimes use a short course of systemic steroids. Sometimes if it is a very chronic sort of seborrheic dermatitis, we also use isotretinoin, low dose isotretinoin, particularly to decrease seborrhea. Phototherapy can be used for widespread agents. Certain newer agents which have been used are topical crisaborole and topical roflumilast. These are both phosphodiesterase inhibitors, and topical omeganan. So this is an antifungal, anti-inflammatory product which has been used in certain studies, but still need to be used and in wider studies to have a better sort of evidence. Apart from this, sometimes we have this sort of phenotypic picture of SIBO psoriasis, where the scaling over scalp sometimes is greasy and sometimes it's dry and silvery. And we see a combination of both psoriatic patches and seborrheic dermatitis. So in those patients, we try and treat with anti-psoriatic agents like methotrexate and all. So these are all. This is in a nutshell about the pathogenesis and therapeutics of seborrheic dermatitis. I hope was of benefit to our listeners. Thank you. Over to you, sir.
Thank you very much, Sumit, for giving us a very, very lucid account of what seborrheic dermatitis is. I'm really surprised at how much there is in, pathology of seborrheic dermatitis. A simple kind of condition that we see in our day-to-day clinics. Just pass it off as a simple, form of dermatitis or eczema, and treat it well. And there's so much of pathology, so much of pathogenesis, and so much of cytokines involved in this also. And so you have really thought well as to what are the intricacies of this difficult condition. So friends, we are going to go to the panel discussion now. And for this panel, I have my very dear friends with me, Dr. Rohit Batra. Dr. Rohit Batra is a consultant dermatologist at the Sir Gangaram Hospital, New Delhi. He's the director of the Derma World Skin and Hair Clinic. He's an adjunct lecturer at the UCSI Kuala Lumpur in Malaysia. He has been the National IIDVIL Secretary. He has been the Secretary of the IIDVIL Delhi State Branch. He is He is a very versatile person in the sense that he conducts several conferences. Particularly well known amongst them is the DAS conference, which is a wonderful amalgamation of various specialties and subspecialties. Thank you, Dr. Batra, for being with us today. We also have with us Dr. Anuj Pal, another young, versatile dermatologist, and he is known across the country for his versatility. He completed his residency from Government Medical College, Punjab. He did his PhD from Trinity College in Seychelles. Then he worked at the Boston University, Massachusetts, and Mona Lisa Dermatology Center in Dallas. He has been awarded the National Laser Certification by Aesthetic Medical Institute in California. He is a very innovative dermatologist because he keeps on posting his pearls in dermatosurgical practice that we really love to go through. Several awards to his credit. I'll not go into the details. I welcome Dr. Anuj Paul, my younger brother, to this panel discussion.
Thank
We
you, sir.
also have
Thank you.
another, thank you, Anuj. We have another budding youngster, Dr. Rahul Arora, with us today, who I have had the privilege and pleasure of working with. He was with me at Sundarlal Jain Hospital. Unfortunately, the hospital closed down, so we have not been working together for some time. But as long as I was with him, Rahul Arora has been a wonderful, help, and he would give me insights into so many newer things in dermatology. Really promising person to have in our fraternity. Thank you, Rahul, for joining us. I
you, sir.
welcome you all to the panel, and I have not made a presentation, and I'm just going to go through certain basic questions that came to my mind when I was, looking at this panel discussion. So let's go to the first question. There's a very thin line between a seborrheic scalp and a seborrheic dermatitis scalp. How do we clinically differentiate between these two? Let's start with Rohit. What do you call seborrhea, and what do you call seborrheic dermatitis?
So seborrhea, when it will be there, it will not be restricted only to the scalp. It will be there on the face also, and of course, seborrheic dermatitis can also occur on face, but the areas are fixed. While seborrhea will be all over the face, and most of the patients come to us with open pores, etc., and seborrhea is there. People complain that, sir, I wash my hair every day in the morning, and by the evening, they are all it's they are oily. So that is what I call seborrhea. And of course, seborrheic dermatitis will be with itching, there will be scaling. At times, if it is more, there will be scabs, crusting, etc. also. And of course, with seborrheic dermatitis, you can have on the around the nose, retroauricular areas, chest, etc. Eyebrows are the areas where it is affected.
Okay, Anuj, how does the treatment of seborrhea versus seborrheic dermatitis differ? Do we treat seborrhea, and if yes, how do we treat it differently than seborrheic dermatitis?
So seborrheic dermatitis, the seborrhea treatment is always going to be there, because what I feel is that seborrhea to me is like something on the scalp, which is the cause, and the symptom is all over the face. You get red patches on the forehead, around the nose, face, and behind your ears, and what Dr. Rohit just said. So to my understanding, the cause is on the scalp and the other seborrheic areas, and the seborrheic dermatitis is symptom. So many times we keep on putting creams on the seborrheic dermatitis, like lesions, red patches, and all. When we stop it, it comes back again. So we need to treat both of them together. So I would prefer treating symptoms along with the cause also. And as far as treatment is concerned, so we have to majorly control the scalp, not the seborrheic dermatitis sites, because it is the generation of the seborrheic dermatitis from that region. So continuous treatment of seborrhea is important, and seborrheic dermatitis, after initial phase, we go to the maintenance phase. That's very nicely told by Sumit also, and I think we'll be discussing more in the panel discussion.
So seborrhea is the basic cause. Seborrhea is to be treated, and you need to keep on keeping the seborrhea under control even after controlling the dermatitis. Okay, now we understand that the basic problem is oiliness, but it comes as dry scales, although greasy, but patient says it is dryness. What creates these scales? Rahul, what creates these scales?
So it is basically the epidermal barrier dysfunction which creates the scales. If you understand the pathogenesis that Dr. Sumit has just said, fungus is just one, malassezia is just one of the component of it. It creates the milieu, which creates inflammation, which ultimately leads to an epidermal increased turnover as well as shedding. And this is what creates dryness. Whatever seborrhea and oiliness we see is one of the part of the pathogenesis, and these sebum glands are part of the pathogenesis. So there is dryness in presence of oil. So if we say there is the dryness is caused by the extensive exfoliation, which is due to the altered epidermal turnover.
Okay, let me go back to Sumit now because he has given us a very lucid account of the whole problem. Sumit, how much role do the hormones have to play? Is it absolutely hormonal? Are all seborrheic dermatitis hormonal? Does androgens have the primary role to play?
So they don't have the primary role to play, but yes, they do have an important role to play, both in infantile seborrheic dermatitis, where it is believed that it's the maternal hormones uh, which are in an overdrive at that point in time, where they cause and stimulate the sebaceous glands, which they are not supposed to be stimulated at that age. And both after puberty, when the sebaceous glands are stimulated, that leads to sebaceous gland activity because of androgens. And also in different prevalence studies, it is known to be seen more commonly in men. And also, seborrhea per se is seen as a symptom of hyperandrogenism. So yes, they do play a role, but it's not like it will not be seen totally in women who don't have hyperandrogenism. They still can have sebaceous gland activity. They still can have more malassezia there. So it is multifactorial, but yes, androgens do play a role.
That brings me to an important question. Is seborrhea or hypersebaceous activity a primary event? Without that, no seborrheic dermatitis will happen?
Sir, I'd like to take that question. Sir, actually, the main important point is genetic predisposition to the sensitivity to the fungal lipases and then the milieu created by those malassezia yeast out there. We may have seborrhea. In fact, in many patients, even in the absence of normal sebum secretion and normal sebal composition, they also seborrheic dermatitis has been seen. And in PCOD, there is seborrhea, but very few girls usually actually present with seborrheic dermatitis. So there has to be a genetic predisposition along with other factors so as to create seborrheic dermatitis out there.
Oh, wonderful. So that brings me to a question. Are yeasts the pivotal component? Is it the yeast that cause the disease, or is it the seborrhea? So you said seborrhea is not so very important. Anuj, do you want to throw light on how important are the yeasts as far as the disease is concerned?
Sir, for me, it is the partnership of three things. Hormone is the main cause. We all talk about what is the cause of acne? It is testosterone hormone. We all believe that the sebaceous gland, they get activated by the testosterone hormone. So hormone is the most important one, which is going to play. Second, it is going to cause increase in the sebaceous secretion. Now, all of us, I have got malassezia, everyone has got malassezia. So when there is more of raw material, which is the sebaceous secretion, the fungus is going to thrive on that, and then it is going to disintegrate into fatty acid, which Sumit was talking about, and that is further leads to go to inflammatory cascade, and seborrheic dermatitis is going to happen. Now, very important is that I have seen many patients, they have got seborrheic dermatitis, very bad seborrheic dermatitis in Delhi, but they go somewhere else, the seborrheic dermatitis is better without taking any medication. So environmental factors do play a very important role, along with other things we are talking, to make the full circle. So I think everyone is playing important role, and fungus, as you said, sir, yes, of course, it is one of the chief component of the whole process.
So the disease is multifactorial, and environment plays an important role. Why does it change seasonally? We have seen that more seborrheic dermatitis happens in winters. Rohit, throw some light on this aspect of the disease.
So, more seborrheic dermatitis occur in winters because another reason behind that, what I personally feel, is that during summertime, people wash their scalp every day, and during winters, they start washing alternate day, or at times people who will wash uh, once a week also. So that is also one of the contributing factors. If you are not maintaining hygiene, it will definitely add to that. Also, the secretion that is there when nowadays people are in a heated environment in winter, the oil secretion is more. That adds to the oil secretion on the scalp also. The secretion that is there on the scalp leads to more of exfoliation, more of epidermal cell turnover, and that leads to seborrheic dermatitis more in winters.
Sumit, you want to add something to this since you've gone through the pathophysiology in detail?
So
Seasonal.
there is more epidermal barrier dysfunction also in winters because of the prevailing conditions, and also because of sometimes we use hot water to wash our scalp. That also leads to epidermal dysfunction apart from less frequent grooming and cleaning. So that leads to more seborrheic dermatitis.
Okay, clinically speaking, it's very important to differentiate seborrheic dermatitis from other conditions. Itchy scalp is a very common, presentation in our clinics. What are the other conditions that mimic this disease and should be differentiated, and what are the pointers to differentiate? Let's start from Rahul.
So the other conditions which may mimic seborrheic dermatitis may be scalp psoriasis or other inflammatory contact dermatitis of the scalp or facial areas. Rosacea may present like seborrheic dermatitis in facial areas, and atopic dermatitis on face may also present with similar itchy lesions on face. So these need to be differentiated with seborrheic dermatitis.
Okay. Anuj, tell me, do you really feel that shampoos help? Is contact time important? What do you tell your patients? Do they have to keep it on their scalp for 5 to 10 minutes? What is the exact way you tell them to use shampoo?
So I tell them, like always, this is the contact time is very, very important. And how I tell them is that like you have to give at least 5 minutes, and whenever you apply, don't consider applying it on the length of the hair. You have to apply in the scalp because the fungus is lying on the scalp. Now what they do is, like I tell them, you just shampoo your scalp, leave it till the time you can brush your teeth and all, so that it gives you good 2 to 5 minutes of like time, and then rinse their like hair with the shampoo.
Wonderful. See, contact time is very important. If they just apply and wash off, it's not going to work. So there are various ways. I tell my patients to apply it into the scalp, rub it for some time, then wash, take a bath on the rest of their body, and then come back to the scalp in the end, because that will give them a contact time of maybe 3 to 4 or maybe 5 minutes. But 5 minutes is what is recommended, which is sometimes not very practical. 5 minutes is a long time.
Winters is very, very difficult.
In winters, you want to get out of the bathroom and
हमारे नौबरी वाले सर थे वो नहीं नहीं
Okay. Can we have the other people muted, please?
जनरल की शक्ल दिखाना
So I want to add here, like many of these antifungal shampoos that are available, many of our patients will complain that they cause a lot of dryness. So what I ask them is that, and then they say that I use this shampoo, I use a color protect shampoo, I use a very expensive shampoo. So I usually tell them that, okay, this is a problem of your scalp. You apply this shampoo on your scalp, and as you said, that first take a bath all over the body till the time you are applying the soap or the body wash all over the body, keep it there, and then you can shampoo your hair with the normal shampoo which you want. So that way people are also happy, and they save a lot on these medicated shampoos. Otherwise they say that I have long hair, doctor sahab ye to ek hafta hi chalta hai. At times that is difficult, and then it causes a lot of dryness also in the length of the hair. So I tell them you use normal shampoo for the length of the hair.
That's a wonderful point that you have brought out, because practically we see this every day in our clinics. Patients tell us, one is, I have colored my hair and I have been given a shampoo by the cosmetologist who is more qualified than the doctor. Two, their hair gets dried out because of these medicated shampoos. Three, these medicated shampoos are expensive, available in small packings. And so these are the practical problems. I think you elucidated it well, how we can take care of this problem. Okay. Apart from topical steroids or salicylic acid, what are the other topical agents? Sumit, you talked about some. Can you elaborate further? What are the other agents that can be used topically to take care of the problem?
Sir, there are this category of agents which are often mentioned in a lot of articles, which is antifungal, anti-inflammatory products, which is pyroxone, oleamine, which has activity both against yeast and also help in decreasing the epidermal barrier dysfunction. Bisabolol is also one. Apart from that, there is tea tree oil, which surprisingly has good evidence in with both as a shampoo and as a oil. We hate oils in seborrheic dermatitis, but this is one oil which has some evidence even in our journals, which in relieving seborrheic dermatitis. Or apart from that, there is zinc pyrethrione, which is an antifungal. It doesn't have any anti-inflammatory direct properties. Zinc pyrethrione is also there, which is an anti-yeast. Selenium sulfide is also one anti-yeast product, which is available as a lotion or a shampoo, which have been used traditionally in this disorder.
Thank you very much, Sumit. Let's come to other orals. How much of anti-fungal agents do we use orally in patients of seborrheic dermatitis? Rahul, do you use it frequently?
Yes, sir. I do use it in patients who are not initially responding to topical or who have an extensive form of seborrheic dermatitis involving multiple areas. I do use oral antifungals.
And which is the antifungal of choice?
Usually I start with fluconazole, and malassezia is usually sensitive to fluconazole. If at all there is not much of a response or there is a frequent recurrences, then I go for itraconazole.
Okay, so do the rest of the panelists agree on use of azoles only and not allylamines like terbinafine?
Yes.
Azoles.
Terbinafine has a lesser sensitivity for malassezia, as we can see even in pityriasis versicolor. It does not give great response.
Yes, yeasts primarily do well with azoles rather than with allylamines. Oral retinoids in seborrheic dermatitis. How much do you people use? Anuj, do you use isotretinoin? No,
Sir,
you are not.
I have used initially, but now I don't use it, sir.
You don't use, and I'll ask you why. Rohit, do you use isotretinoin in seborrheic dermatitis?
So only when it is seborrheic dermatitis, patient is also complaining of scalp folliculitis, then I go for oral isotretinoin.
Okay, what about you, Rahul?
So in patients with seborrhea per se, there are patients who have extensive seborrhea, I use low dose isotretinoin, and in patients who are recurrent and relapsing very frequently, I do use oral isotretinoin. And since it is targeting one of the core pathogenesis, which is sebum, it is not only sebostatic, it is also keratoplastic. So in both in epidermal barrier dysfunction as well as sebaceous secretion, it is helping. So I think it is more of an underutilized molecule in chronic seborrheic dermatitis, and I think should be used more often.
Sumit, what is your take on that?
So I agree with Dr. Rohit sir and Dr. Rahul sir also. And particularly, I want to add that very low dose, even 10 milligrams or even sometimes 5 milligrams, if it is available, works nicely for seborrheic dermatitis. We don't have to give higher doses, which could lead to cheilitis and other unfavorable adverse effects. So particularly scalp folliculitis, as sir mentioned, is one condition which doesn't respond to also rest of the treatment agents.
So it is 1 no against 3, yes, sir.
No, I'll add my vote.
I have to give now my explanation of no, I think.
Yes.
After you, sir, after you.
Okay. I would be on the 3 side. I would add one more vote to that. I'm a very avid user of isotretinoin, low dose, of course, about 5 to 10 milligrams. And I find it quite useful. And as Rahul very aptly elucidated, the 2 components that are taken care of with isotretinoin, one is seborrhea and the 2 is keratoplastic effect of the isotretinoin. So back to you, Anuj.
Okay, I'm the patient and Dr. Rahul is now there. I am not suffering from a disease, Dr. Rahul. It is a physiological process. That's how I tell my patient that dandruff is not a disease. It is a physiological byproduct of your body जो बन के गिर रहा है और आपको seborrheic dermatitis हो रहा है. You tell it very right. Okay, Dr. Paul, you have to take now isotretinoin. Dr. Rahul, कब तक दोगे?
Sir,
you cannot cure my problem, but कब तक दोगे? Till what time? And after that, when you stop it, whether it will start again or not.
The same holds true with acne also in isotretinoin.
No, that's different. Acne is different. This is like Siboria is like lifelong problem. It's going to go for years and years and years. I
Dr.
tell
Rohit,
you. So
Yeah, we
my
will.
take I'll take only 30 seconds, sir. My
Yes.
take on that is that okay, let's draw a line on the forehead. That is the cause, and the symptom is on the face, right? We are going to treat these two different things now together. First is face. Take very mild cortisone for 3-5 days. It says zarurat hi nahi hoti, and followed by pimecrolimus, one of the best drug in the world for seborrheic dermatitis. But if you go only with this thing on the face, it'll come back because you haven't addressed the cause. Now the cause is here. In this case, you are going to give one lotion, like I prefer, cortisone salicylic paste lotion for 3 to 5 consecutive days, followed by twice a week, and then you take off the lotion and continue with the shampoo. You have to train your patient that whenever you start itching the scalp or you see scaling of the scalp, you have to act that day. You don't need me. But if you wait again for a few days, it is going to the cycle is going to start again, and that's how it's going to end up. So this is my take on this, and that's how I
Okay.
tell my patients.
Okay, we'll have to wind up, but quickly, a very important aspect of the panel is I want to know your view on these newer combinations. Particularly now we have a laliconazole, salicylic acid, and zinc pyrithione combination. I want to know about your take on this combination, and then we can close down. Yes, please. Can we have it from Sumit first because he has done an in-depth survey.
Sir, frankly speaking, sir, we do have zinc pyrithione and salicylic acid based treatments available. And although laliconazole have shown improved sort of efficacy in vitro studies against different Malassezia species, particularly the ones which are prevalent in India, the restrictum and the globosa Malassezia species. But again, on a clinical point of view, I don't frankly know whether it will have an improved sort of, or whether we need it, particularly keeping in view that we have a dermatophyte sort of epidemic already going, uh, and we want to expose more antifungal agents to the community. I frankly have little guarded sort of viewpoint on it. Sorry, Lupin, but that's what I believe.
Okay. So I'm closing on the note that there's a new novel combination available with laliconazole, which has not been available as a shampoo until recently. In combination with zinc pyrithione and salicylic acid, laliconazole a very potent antifungal, better than ketoconazole in most of the situations against Malassezia. Zinc pyrithione is a potent antifungal, has a different mechanism of action, helps to balance the increased triglycerides, cholesterol, and ceramides. Salicylic acid is a proven keratolytic, a keratoplastic, an antibacterial, anti-inflammatory, and has synergistic action with antifungal. So this combination seems to be quite promising to use in future. Yes, Rohit, your closing remark.
So I have used the product myself, and I suffer from a sort of seborrheic dermatitis because of the receding hairline and receding volume. So I have to shampoo, and I must say that it gives better of effect than the other antifungal or the steroid-based shampoos that I have used. Uh, when it comes to washing, you need to give prescribed something to your patients, and I guess that this is a better off than giving a patient a steroid based shampoo.
Thank you very much, Rohit, giving us the first-hand experience with this product. And thank you very much, panelists. Thank you, Sumit, for that wonderful presentation. I was really impressed. And thank you, Rahul. Thank you, Anuj, for your inputs. And thank you, Gaurav and Team Haryana for giving us this opportunity. Back to you, Dr.
Thank you very much, sir. It was always great, sir. Thank you.
Thank you, sir. Thank you, Team Haryana.
Thank you, and
Thank you. Thank you, moderator. Thank you, all the panelists, for a very nice discussion. It was really a nice experience. We shall now take the questions if there are anyone. There is one question. How to deal with dryness due to the shampoo, the antifungal shampoo?
Okay, let's go to Rohit for that because he has first-hand experience with many of them.
So I have already answered that in case my patients are applying some anti-dandruff, anti-seborrheic dermatitis remedy, I ask them to use and the normal shampoo in the length of the hair. And of course, in females, we ask them to use a conditioner from where their pony starts. In males, I ask them that okay, they can use one drop of serum if they want to groom for themselves. Otherwise, there is no need.
And avoid hair oils.
Yes,
Big
that's a
no,
strict
big,
no.
big
Whether
no,
you
big
have
no,
seborrheic dermatitis or no, hair
big no.
big no to hair oils.
Okay, Dr.
Thank
Gaurav,
you.
more questions?
No, sir. Thank you. Thank you.
Your closing remarks, please.
Yeah. So thank you, sir. Thank you, all the moderator, all the panelists, and the moderator. It was really a very nice discussion. I thank everyone on behalf of IADVL HSP.
Thank
Thank
you.
you, sir.
Thank you, Dr. Gaurav.
Thanks, Sumit, Rahul, Anuj, and Rohit. Thank you very
Thank you,
much.
sir. Thank you.
So we now move on to the rest of the free paper session. I would like to invite Dr. S.P. Singhal and Dr. Sushil Batla for chairing the session. Dr. S.P. Singhal.
Should we start? Now, further, we should move on. Should I start? Now, I request Dr. Aditya Gujarati, Resident IMSR Ambala.
Yes, can I start? Yes, sir. Should I start?
Please stand, Dr.
Okay. Uh, Good evening, everyone. Today I'll be presenting a paper on clinical profile and quality of life in patients of recurrent and recalcitrant dermatophytosis. Dermatophytosis is the superficial fungal infection of skin without any systemic involvement with or without tissue reaction. The global presence of this disease is around 25%, with the increased incidence in human humid areas. Among the three species, the anthropophilic species are mostly confined to humans and spread via direct contact or fomites, which also act as reservoirs. So this is a clinical photograph of dermatophytosis. There is extensive involvement with multiple lesions and eczematization. This patient also had lesions on axilla and groin. Though previously presumed to be a mild disease, changing dynamics of this disease have proven it surprisingly difficult to treat in many cases. There is usually a pattern that the patient follows, that where he says that the lesions do get better when he's on treatment, but as soon as he stops the treatment, the lesions have recurred. So this is often labeled as difficult to treat tinea. There haven't been many studies in this topic. So 500 clinically diagnosed patients with recurrent dermatophytosis were assessed. KOH mounts were prepared in all cases, and a few samples were also sent for culture and identification of species. Quality of life was assessed using DLQI and Skindex 16. So this is a clinical photograph of Tinea manum. Tinea fasciae. This patient had a long history of application of topical corticosteroids, and as you can see, almost the entirety of the face has been involved with a clear border around the jaw. Here are few of the observations where we can see around 18 to 30% of 18 to 30% 30 age group are most affected. Same goes with body surface area. 1 to 10% of the body surface area was most of the patient lie in this category, with a very few outliers here. Same with goes for duration of disease. 0 to 23 months was the most common group, with a very few outliers. When it came to topical corticosteroids, that is the history of topical corticosteroids application, we saw that it was a majority. It made a majority. A part of the major group was a triple combination, that is of antifungal, antibiotic, and steroid, followed by it only after unknown. That is, the patient did not have the knowledge of what topical they were using, which also points to the lack of knowledge, or even the lack of interest that the patient has on the treatment that he takes for his actual problem than the problem itself. When it comes to clinical examination, we saw that the combination of tinea cruris and tinea corporis was the most common, followed by a combination of tinea cruris, corporis, and fasciae, and tinea cruris, corporis, and fasciae alone. When it came to comorbidity, we found that obesity was the most common comorbidity, unlike other studies which have majorly implicated diabetes to be one of the major causative factors. When it came to history of medications, we found that 98% of the patients had history of oral medications, 96% had a history of topical medications, and only 22% of the patients had a history of injectable medications. We also found a significant relation between use of topical steroid combination preparation and number of recurrences of disease that the patient had. There was also a significant patient with recalcitrant disease also had a significantly higher body surface area involvement. We also found that homemakers were most commonly affected, and with a higher body surface area and a duration of disease. The possible reason for this is because of the practice of cooking, because there have been studies that have proven that home cooking is to be a major risk factor for for tinea corporis. The reason for being this is most likely that the large amount of exposure of heat for a prolonged period of time, and the sweating that is associated with that, provides an ideal milieu for dermatophytosis to grow. We also found the positive family history in 66% of the patients, and we found that the patients with current family history, that is the patient who had a family member who was currently suffering from dermatophytosis, had higher number of recurrences than a patient with a past family history. When it came to mycological examination, we found that KOH bound positivity was 83.8%. This is actually higher than what we usually see with other studies. This could be because of the recurrent nature of the disease. When it came to mycological examination and species identification, Trichophyton mentagrophytes was the most common, followed by Trichophyton rubrum and Microsporum ferruginum. This followed the same pattern as in normal dermatophytosis, as in previously reported, of the shift in species from rubrum to mentagrophytes, and the same now holds true for even, as we can see, even resistant and recalcitrant dermatophytosis, which have shown that mentagrophytes to be a major part of the causative agents. Here's the LPCB mount of Microsporum ferruginum. When it came to personal hygiene, we found that 24.2% of the patient did not take a soap bath. They did not take a bath with soap. This was on the advice of a quack and followed by self. The self part is actually very important because it actually points to the misconception of the patient of the disease that they are suffering from. We also found that 32% of the patient washed their clothes by hand. They also had a significantly higher body surface area involvement and number of recurrences. The possible reason for this is because when patient washes their clothes by hand, the contact period of the cloth with the detergent is significantly lower, because the average cycle for a wash cycle, that is for a washing machine, lasts for about 10 to 21 minutes. When it comes to hand, if let's say the person barely reaches 5 minutes before he has washed off the detergent, so this could be a
Dr.
possible factor
Ajinkya,
for that. Yes, sir.
Yeah, you're just running short of time.
Yes, I'm just winding up. Just a minute.
Yeah.
Okay. 14% of the patient had a history of towel sharing. We did not find a significant relation between towel sharing and family history. Here, the patients who did not take a soap bath had a higher body surface area, had a higher skin index score, and higher number of recurrences. So here are a few of the findings. As we can see, both DLQI and skin index 16, that is the higher number of the skin index 16 and DLQI, these patients have also had a higher duration of disease and number of recurrences. knowledge of disease, we found that the patients who did not have the knowledge of disease had a higher body surface area involvement. So the take-home message here is that in the changing dynamics of disease, there are factors like personal hygiene, illiteracy, occupation, neglect, steroid medication, then lack of knowledge and knowledge of disease and lack of counseling are something that everyone should consider while treating these cases. And when we treat these patients, almost every patient has to be treated and has to be counseled as to what he should be doing and not be doing in order to prevent the recurrences and to prevent it being from a recalcitrant nature. Thank you.
Thank you, Dr. Gujarati. Next. Now we request Dr. Anuradha Yadav, third year resident, to start her.
Yes, sir. Shall I share my screen?
Is there?
Am I audible, sir?
Yes, doctor. Please share your screen. You are audible.
Yes, ma'am.
Hello everyone, this is Dr. Anuradha Yadav, third year PG resident in MMI MSR, Mulana, Ambala. I'll be presenting my paper on clinical dermatoscopic and quality of life study in patients of facial hypermelanosis. So facial hypermelanosis is a clinical feature of a diverse group of disorders which have variable but overlapping features. It is most commonly seen in females. It comprises of conditions like melasma, lichen planus pigmentosus, Reals melanosis, etc. Exact etiology of most of these disorders is not clear. Sunlight exposure, genetic predisposition, pregnancy, various cosmetic products like drugs like OCPs, anesthetics, etc. are implicated in the pathogenesis of most facial hypermelanosis. As it forms one of the major group of patients visiting dermatology OPD, so we did a prospective observational study to characterize clinico-epidemiological and dermatoscopic features of facial hypermelanosis and to know the effect of treatment on quality of life of these patients. We enrolled 50 patients of facial hyperpigmentation of either sex and of age group 18 to 60 years. A thorough history was taken, complete dermatological examination. Quality of life of patient was reassessed using DLQI and Melascol scale. Routine blood tests were done. Woods lamp and dermatoscopic evaluation of the lesions was done. A 4 mm punch biopsy was taken for histopathological examination wherever required. Relevant treatment was given to every patient as per the diagnosis. Patients were kept in follow-up and were reassessed at the end of 3 months on the basis of clinical dermatoscopic evaluation, and their quality of life was recorded again. So majority of the patients belong to 31 to 40 years of age group. Female to male ratio was 3.16 ratio 1. 32% of the patients had facial hyperpigmentation since last 1 to 2 years. Family history was present in only 6% of the patients. 30% of the patients had associated disease, of which hypothyroidism was most common. 72% patients had taken previous treatment in the form of topical or oral medication. Cosmetic use was reported in 40% of the patients. So in this study, we came across 11 different categories of facial hypermelanosis as shown in this table here. The most common diagnosis was LPP followed by melasma. So first figure here shows centrofacial melasma, while the next photograph shows a Woods lamp examination of the same patient showing accentuation of the lesions. On dermatoscopy, most common observed pattern was accentuated reticular pattern. Out of 50 patients, 18% had low hemoglobin. Thyroid stimulating hormone was raised in 14%, while 4% had raised blood sugar. Peripheral blood film values were normal in all 50 patients. At presentation, majority of the patients had very large effect on their quality of life. After 3 months of treatment, no effect on quality of life was seen in most of the patients. Total mean DLQI score decreased from 7.86 to 4.78 after 3 months. Similarly, melascol also decreased from 36.04 to 26.36 as shown in this table here. Females are more concerned about their cosmetic problems and tend to consult doctors more than males for aesthetic problems. This was also observed in this study as 76% patients were females while males were only 24%. Various implicated factors like pregnancy, OCPs, cosmetic use, drugs, etc. are more common in the adults, which was seen in this study also as most of the patients were in age group of 1 to 40 years. Intense sun exposure is believed to play an important role in development of facial hyperpigmentation. Housewives who are involved in both indoor and outdoor work were most commonly affected group. Family history was present in only 6% of the patients. All of these had melasma. Hence, it is rightly considered as an important risk factor in the development of melasma. In this study, we came across 11 different LPP was the most common cause, followed by melasma. This may be because melasma usually involves less area, so these patients were not included in this study. 7% patients were found to have hypothyroidism as TSH was raised in them. PBF was done to see findings related to vitamin B12 deficiency like macrocytic anemia and thrombocytopenia, etc. Wood's lamp is used to determine the depth of pigment as epidermal melasma shows accentuation while dermal melasma doesn't. In the present study, 18% patients had accentuation of lesions. Facial melanosis had significant effect on the quality of life in most of the patients because of its disfiguring nature. After 3 months of treatment, there was a statistically significant decrease in mean DLQI and mean melascol score 4. So the study highlights the advantage of correlating the clinico-dermatoscopic and histopathological findings while arriving at an accurate diagnosis and further management. Facial melanosis has a significant negative effect on quality of life. Facial pigmentation, although asymptomatic, affects self-esteem because of cosmetic concerns. Thank you.
Thank you, Dr. Anuradha.
Thank you, sir.
Next. Now we request Dr. Arushi Kakkar to start her paper.
Good evening, sir.
Good evening. I'm Dr. Arushi, PG, third year resident, MMI MSR, Maulana Ambala.
Just a minute, sir.
Arushi, please share your screen.
Yeah, just a minute, ma'am.
So the topic for my paper presentation today is evaluation of serum levels of interleukin 17 and 22 in leprosy patients. So patients with tuberculous leprosy, they are known to have Th1 subset, whereas in lepromatous leprosy, Th2 subset is there. In both the reactions, there is distinct polarization to Th1 type, but in some cases, Th0 profile is also known, in which interferon gamma and interleukin 4 both are expressed. So recently, a subset of Th17 cells has been identified in humans that produces interleukin 17 as the chief cytokine. CD4 plus TLP17 cells, they play a crucial role in autoimmune inflammation, tissue pathology, and clearance of pathogens. They yield interleukin 17A, 17F, interleukin 22, which results in tissue inflammation and destruction. So it seems that decreased levels of interleukin 17 has a role in leprosy progression. Interleukin 22 appears as one of the main proteins involved in Th22 response, which can act as both pro-inflammatory and anti-inflammatory cytokine based on the disease. So there's a lot of data regarding the role of CD4 and CD8 cells in leprosy, but there's positive literature with reference to Th17 cells in leprosy. So targeting interleukin 17 and 22 can be a future helpful approach to limit this endemic disabling disease. So we planned the present study to assess the role of 17 and 22 interleukins in leprosy. So in my study, we took 34 patients in the age group of 22 to 75 years, and we excluded all the patients who were on anti-leprotic treatment or some kind of immunosuppressive or immunomodulatory treatments. All the demographic parameters, including the age, sex, occupation, region, were recorded. Detailed history, family history, drugs, socioeconomic history was taken. Dermatological examination was done. Duration of disease, type of leprosy, slit skin smell positivity, reactions, if any, were recorded. Interleukin 17 and 22 serum levels, they were assessed using ELISA. Serum levels were assessed for both the cases as well as the controls, and they were tabulated according to duration of disease, slit skin smear, type of leprosy, and reactions. So demographic parameters of the cases and controls that we included were age, gender, then the occupation. So in this study, mean age of cases was 40 years, and there was slight male preponderance in my study. That is, the ratio is 1.26 is to 1, male is to female ratio. And the housewives were more in number as compared to the other occupations. And then distribution of cases was done based on disease-specific parameters, that is the duration, the diagnosis, then slit skin smear positivity or negativity, the type of reaction, whether it is type 1 or type 2. And in this case, maximum number of cases were under 3 months, that within 3 months of duration. Then we divided on the basis of types of leprosy, right? So 10 cases were reported of lepromatous leprosy, 5 each of type 1 and type 2 reaction, and 20 cases were slit skin smear positive. So mean interleukin 17 and 22 levels were also assessed among cases and controls. These are the values. So interleukin 17 as well as interleukin 22 were raised in cases as compared to controls. Interleukin 17 was 192 picogram per ml and 22 was 244 picogram per ml. So there was statistically significant difference when it was compared to controls. Similarly, interleukin 17 and 22 levels were compared based on the slit smear. These are the observations, as you can all appreciate. So interleukin 17 levels were also based on the diagnosis. So what we did was we divided the leprosy patients in 5 groups based on the Ritridge-Optin criteria, and we took 2 groups separately. That is, we separated the reactional patients, type 1 and type 2 reaction. So we took 7 groups in all. So mean level of interleukin 17 was lowest in lepromatous leprosy, which was around 42 picogram per ml, and it was highest in ENL, that is type 2 reactions. It was around 633. So these values were statistically significant. And interleukin 22 was similarly gave significant differences. Like in lepromatous leprosy, the value was quite low. It was around 82, and in reactional patient, it was very high. So Th17 cells have recently been emerged as the third subset of T helper cells, which plays an important role in many infectious diseases. In our study, interleukin 17 was raised all across the various leprosy groups with maximum levels in leprosy patients. Mean levels of interleukin 17 in leprosy patients was higher as compared to controls. Same was the case with interleukin 22. So augmentation of Th17 cell activity can also explain the inflammation associated with leprosy reactions. In our study, we've observed that interleukin 17 levels and 22 levels in leprosy patients are higher as compared to controls, and 17 and 22, they were raised in type 1 and type 2 reactions, but they were quite low in interleukin 17 and 22. They were quite low in lepromatous leprosy in interleukin 17 and 22. So targeting Th17 may be a future helpful approach to limit this endemic disabling disease. Thank you.
Thank you, Dr. S.P. Singer and Dr. Sushil Bhatta.
Thank you.
Now I would like to invite Dr. Aneet Mahindra and Dr. Jayanti to chair the next session.
Now I'll request Dr. Preet Kaur to present her topic entitled Clinical Epidemiological Profile of Dermatophytosis in QH positive patients in a tertiary care hospital in Gurugram. She is a junior resident from SGT Medical College and would like to hear her views on this present era of dermatophytic epidemic. Dr. Preet, please.
Can you hear me, sir?
Yes, you are audible.
Should I start, sir?
Yes, please start.
Good evening, everyone. I'm Dr. Preet Kaur, third year postgraduate resident from SGT Medical College, Gurugram. My topic for today's paper presentation is Clinico-Epidemiologic Profile of Dermatophytosis in QH positive patients in a tertiary
Dr.
care
Preet,
hospital in Gurugram,
please
Haryana.
share your screen. Please share your screen.
Dr. Preet, do you want me to share the screen?
No, ma'am, I'm sharing. Just a minute. Is it okay, ma'am? Can you see my screen?
Dr. Preet, we are not able to see your screen.
Just a minute, ma'am. Just a minute, ma'am. Ma'am, is it visible now?
No, Dr. Preet, it is still not visible.
Dr. Preet, shall I share the screen? You can give your live presentation. Is that okay?
Okay, ma'am.
Okay, right. You able to see?
No, ma'am.
Are you able to see the screen?
Yes, ma'am. It's okay now, ma'am. Should I start, ma'am?
Dermatocytosis in QH positive patients in a tertiary care hospital in Gurugram, Haryana. Dermatophytosis, as we all know, is the most important subtype of superficial cutaneous fungal infections. It affects 20 to 25% of the world population, making them one of the most frequent forms of cutaneous infections. Its prevalence is more in tropical and subtropical countries like India, where heat and humidity remains high throughout the year. An increasing trend has been seen over the last few years, and nowadays more cases being seen are chronic, unresponsive to treatment, and recurrent. So, taking this into consideration, present study was undertaken to determine the clinico-epidemiological profile of patients in district Gurugram of Haryana.
This was a descriptive observational study carried out between December 2018 and June 2020. Here, 220 clinically diagnosed cases of dermatophytosis were taken. Their skin, hair, or nail specimens were sent for direct microscopic examination by KOH mount, and out of which 170 positive cases were enrolled for the study. Their demographic details and clinical aspects were noted, and chi-square test of independence was used for statistical analysis. Patients of all age groups and both sexes were included in the study, whereas patients on any oral immunosuppressant drugs and those with poorly controlled diabetes were excluded from the study. Approval was obtained from the Institutional Ethics Committee dated 24 December 2018, and written informed consent was taken from all the study participants. Now coming to the results, out of 170 cases of dermatophytosis, 109 were males and 61 were females, and maximum number of cases were seen in the 21 to 30 years age group, followed by 31 to 40 years age group. Distribution by area of residence showed that majority of the patients were from the rural background. As the catchment area of the hospital comprises mostly of the rural population, this was followed by urban and semi-urban areas. Assessment of severity of disease in terms of body surface area of involvement showed mild disease in 55%, moderate in 28.6%, and extensive in 16.4%. So, a significant number amounting to 45% had moderate to extensive disease. Assessment of chronicity of disease in terms of duration of illness showed that 45.9%, that is almost half of the patients had the illness from last 1 to 6 months duration, while 38.2% had the illness from more than 6 months, and only 15% were such patients who were having the illness from less than 1 month. In our study, chronic dermatophytosis was found in 38.2% patients. Distribution of patients by clinical profile showed that 70% of cases had mixed presentation, that is, there was involvement of more than one site. Of it, tinea corporis with tinea cruris was the commonest, followed by tinea corporis with tinea cruris with tinea faciae. 30% of the patients showed single site involvement, of which tinea cruris was the commonest, followed by tinea corporis. Now, table 4 is showing association between type of dermatophytosis and the age group. As evident from it, tinea corporis and cruris were found in significantly large numbers in 18 to 65 years age group as compared to 0 to 17 years, and the difference came out to be statistically significant. Tinea faciae was found in equal numbers in both these age groups. Tinea capitis was found to affect 0 to 17 years age group more than 18 to 65 years, but this difference came out to be statistically non-significant. Tinea pedis and tinea inguinum cases were not seen in less than 18-year patients, and the sample size of elderly was less, so it was not compared with other age groups. Was 21 to 30 years, followed by 31 to 40 years. 21 to 40 years age group being the most maximum activity and increased perspiration. The male to female ratio was found to be 1.8 is to 1. 45% of cases had moderate to extensive disease, and almost half chronic dermatophytosis was found in 38% patients. Tinea cruris et corporis was the commonest clinical presentation, followed by tinea cruris alone. Now, as we conclude, this study emphasizes the importance of repeated analysis of epidemiologic profile of dermatophytosis to enable correct therapeutic and preventive management of these conditions. Thank you so much for your kind listening. Very good.
Thank you, Dr. Preet. The next speaker is Dr. Nikita Gupta from SGT Medical College, and she has a very interesting topic, a prospective study of association between Fitz-Curtis syndrome and non-alcoholic fatty liver disease by assessment of liver enzymes and ultrasonography and reassessment after treatment. So over to you, Dr. Nikita.
Hi, good evening, sir. I'm Dr. Nikita Gupta from SGT Medical College. Today I'll be presenting an oral paper titled A Prospective Study of Association Between Fitz-Curtis Syndrome and Non-Alcoholic Fatty Liver Disease by Assessment of Liver Enzymes and Ultrasonography and Reassessment after Treatment. Pelvic inflammatory disease is an infection of the female upper reproductive tract. Sexually transmitted infections such as chlamydia trachomatis and Neisseria gonorrhea are the commonly implicated pathogens. Fitz-Curtis syndrome is an inflammation of the liver capsule with PID. It occurs in up to one-fourth of the patients with PID. It classically presents as sharp pruritic right upper quadrant pain. Non-alcoholic fatty liver disease is a spectrum of disease from fatty liver to non-alcoholic steatohepatitis, fibrosis, and cirrhosis. It has been observed that FHC syndrome was associated with elevated transaminase levels, which responded to antibiotics, strengthening the fact that perihepatic inflammation was responsible in the causation of FHC syndrome. Our aim is to establish any relationship between FHC syndrome and non-alcoholic fatty liver disease. The inclusion criteria of our study were newly diagnosed cases of FHC syndrome aged 18 to 60 years. The exclusion criteria were history of any alcohol ingestion, underlying liver disease such as liver abscess or metastasis, and patients already on antibiotics. The study procedure comprised of taking clearance from the institutional ethics committee, followed by taking a written informed consent as per Helsinki Declaration from all the patients. Patients were diagnosed with PID using CDC guidelines of 2015. All those patients who additionally had right tenderness were diagnosed as FHC syndrome. Patients were evaluated by doing whole abdominal ultrasonography and liver function tests. These were then treated with doxycycline 100 mg twice a day for 4 weeks. Repeat liver function tests were done at the end of 4 weeks and 8 weeks, and a repeat ultrasound scan was done at the end of 8 weeks in those found with abnormalities. Results. Table 1 shows distribution of the study population having FHC syndrome according to age groups. Here, the average age of patients having FHC syndrome is 35.52 years plus minus 11.25 years. Table 2 shows the distribution of study population according to age group who have fatty liver on ultrasonography. 33.3% of our patients showed fatty liver, 85% patients had grade 1 fatty liver, and 15% patients had grade 2 fatty liver. We did not find any case with fibrosis or cirrhosis of liver. Mean levels of AST, ALT, and ALP were found within normal range. Those with fatty liver had a statistically significant raised liver enzymes as compared to those without it. Table 3 shows the comparison of mean AST levels before and after treatment. Here we can see that the mean AST levels in patients with fatty liver is significantly higher than those without it. Also, a significant reduction in the mean AST levels is seen in patients with fatty liver after 4 weeks and after 8 weeks of treatment. Similarly, here we can see the mean ALT levels in those with fatty liver is significantly higher than those without it. Also, there is significant reduction of the mean ALT levels in patients with fatty liver after 4 weeks and after 8 weeks of treatment. Table 5 shows the comparison of mean ALP levels. How the that patients having FHC syndrome for a longer duration are significantly at a much higher risk for development of NAFLD. Fatty liver regressed back to normal in 12.5% of our patients after treatment. This highlights that chlamydia infection could be a causative factor in some cases of NAFLD. Treatment can lead to regression of both pelvic inflammatory disease as well as fatty liver. This possibly is also the reason for a significant reduction in the level of liver enzymes post-treatment. Now, to conclude, in females, PID is common, often neglected, and frequently being missed by clinicians. We suggest that perihepatic inflammation can cause non-alcoholic fatty liver disease in a few cases, as we found a significantly higher proportion of non-alcoholic fatty liver disease in cases of FHC syndrome as compared to general population. Almost one-sixth, which is 16.12% of our cases, showed regression of non-alcoholic fatty liver disease, and there was also a significant fall in the elevated hepatic enzymes after treatment of FHC syndrome. Therefore, it is very important to promptly diagnose and treat PID and FHC syndrome to prevent the above-mentioned complications. Thank you.
So thank you, Dr. Nikita, for your excellent presentation on this rare topic.
Thank you, sir.
Thank you, Dr. Anith. Thank you, all the speakers. And good night to everyone. See you again tomorrow at 4 p.m. Thank you and good night.